Dr. Ajay, Dr. Bipul, am I audible? So, Dr. Ajay?
हाँ एक मिनट डॉक्टर ललन 2 मिनट उसमें साउंड डॉक्टर ललन बोलो जरा
Yes, yes, good morning. Good morning. नहीं आ रही आवाज? Good morning. Dr. Ajay? Yeah, Dr. Bipul?
हेलो हेलो
Yeah, Dr. Ajay, am I audible?
डबल ए वाले सेल चाहिए होंगे या तो यहाँ से किसी को भेज के ना पैसे दे दो डोरा सेल वाले सेल
हाँ, Dr. Ajay? चक्कर हो गया यार.
उससे हेलो
Yeah. Dr. Ajay?
हाँ हाँ
अब आवाज आ रही है?
यस यस इसका भी वॉल्यूम
Yeah.
ब्यूटीफुल इसका भी कुछ आप शुरू करो डॉक्टर ललन इसका ऑडियो नहीं पकड़ेगा ये माइक इसके पास में कर सकता हूँ अरे नहीं ये हाँ ये ऑडियो ना सिस्टम हाँ हेलो डॉक्टर ललन
Yeah.
नहीं सर इसको सॉफ्टवेयर है नहीं ले रहा ये छोड़ दो हेलो
हाँ, बोलिए अजय, शुरू
हाँ
करें?
हाँ ठीक है
आप शुरू कर दो, मैं शुरू कर देता हूँ, बताओ.
आप शुरू कर दो वी आर लाइव नाउ
Okay. So, good morning, everyone, and it's my pleasure to welcome all the faculty and participants across the country. I must congratulate and compliment Dr. Ajay Gupta and Dr. Bipul, my friend, for this initiative under the able guidance of Professor Jagdish Chandra sir. So I have been assigned to talk on the blood component therapy in neonate, the current evidence and practices. We all know that the blood component therapy is one of the most frequently performed intervention in the care of preterm and sick newborn in an ICU. And these may be PRBC for the treatment of anemia, platelets concentrate for thrombocytopenia, FFP for management of clinical coagulopathy. However, the rational use of component is not being always followed by most of the NICU, leading to excessive and unnecessary transfusion. Transfusion has its own potential harm, especially in preterm neonate. Very importantly, the transfusion can be avoided or decreased by adopting a standard transfusion guideline. So I'll be discussing threshold for transfusion, some of the basic principles, why to follow the guidelines, how much to transfuse, monitoring, a strategy to minimize transfusion, and eventually the key messages. And all this will be discussed with respect to evidence, recent guidelines, and practices. Some of the basic principles for transfusion in neonates are: avoid using whole blood, use component as far as possible. Guidelines provides a list of acceptable clinical situation and should not be served as absolute indication for transfusion the component. The physician should take into account the general condition of the infant as a whole and not to treat.
Please go into full screen mode. Full screen. Presentation mode.
प्रेजेंटेशन मोड में ही है आज। नहीं दिख रहा है क्या? ठीक नहीं, इसमें कुछ दिक्कत आ रही है, दिख नहीं रहा है क्या? प्रेजेंटेशन मोड में ही है।
Continue.
Okay. So always judge the risk benefit ratio while deciding the transfusion. So why do we need to follow this guideline? One must tend to give transfusion when it is not required. Nearly 40% of the preterm below 1500 grams and 95% below 1000 grams receive a PRBC transfusion. Newborns are at higher risk of complication related to transfusion. And unrequired transfusion may put preterm baby at risk of infection, acute blood transfusion reaction, fluid overload, and suppression of intrinsic stimuli of the blood production. So that's why we need to follow the guideline. To follow, let us first discuss about the most frequently used component, that is the PRBC. Multiple landmark RCT of restrictive versus liberal strategy in transfusing PRBC in neonates were conducted from 2000 to 2020. Initially, there was no conclusive data, but later on, these are the liberal versus restrictive approach, different studies. And this is the Cochrane review of restrictive versus liberal policy in transfusing PRBC in neonate, also reported a modest reduction in the transfusion with no adverse effect like death or developmental delay in restrictive strategy. Hence, it is recommended to follow a restrictive threshold policy for PRBC transfusion in preterm. So based on the current evidence, currently the restrictive strategy is followed in most of the unit as suggested by British Committee on Standard Hematology, and same has been endorsed by NNF CPG guideline. As you can see, the guideline is categorized the neonate in 3 categories, that is ventilated one, and the baby on oxygen or CPAP, and baby without any support. Further, they had been classified into less than 1 day, 2 to 7 days, and 7 days to 14 days. So if we take 7 days to 14 days, then if the baby is ventilated one, then we take the cutoff of 10. If it is less than 10, then we have to transfuse the baby. If the baby is on CPAP or oxygen, then the cutoff value is 9.5. If the baby is not on any support, then the value is 7 to 7.5, 7.5 to 8.5. This is the snapshot of our CPG guideline stating the same threshold level, and accordingly, the recommendation has been given. So how much to transfuse? A volume of 10 to 15 ml per kg at a rate of 5 milligram per kg per hour. This will reduce the chances of TRALI, that is transfusion-related acute lung injury. Whereas in case of cardiac failure or extremely low birth weight, the volume should be less than 10 ml per kg. The top-up transfusion, more than 20 ml per kg, is not recommended because of the risk of the transfusion-associated circulatory overload. The same has been recommended by the NNF CPG guideline. Coming to the preparation and administration, the PRVC are prepared from the whole blood cell after centrifugation within the first 8 hours of the collection. These are the different preservative and the shelf life. That is, if we use the SAGM, that is 45 days, like CPDA 35 days. PRVC should always be stored between 2 to 6 degrees centigrade, and it should be liquo-reduced, irradiated, and CMV negative RBC. And same has been also suggested by CPG guideline of the NNF. The blood selection is more important in case of the double volume exchange transfusion. In all cases, but the more important in double, where there are maternal antibody. So if the baby's blood group is O, then we need to take PRVC O. And if we talk about the FFP and platelets, where we can use either O, A, B, or AB, right? For in case of the RS positive infant, we can take either positive or negative. And in case of negative only, we can take negative PRVC. Now let us know if one should transfuse fresh or old blood. So based on the APRI and Cochrane 2015, there is no difference in the outcome. So one should follow the existing standard practice of the blood bank, that is oldest should be used first. And this the same guideline, same recommendation has also been given by the NNF CPG guideline. However, in certain conditions like intrauterine transfusion, we should use less than 5 days blood. And when we use the large volume transfusion, exchange transfusion, in that condition, we may use the fresh blood. So should we warm the blood before transfusion? Yes, we should warm the blood before transfusion. PRVC is stored at 4 to 6 degrees, and hypothermia can develop after massive transfusion. So inline blood warmer should be used for all RBC transfusion. This is preferably because it is not available everywhere, and radiant heater and hot water should be avoided. Bottles should be avoided because they can result in hemolysis of the RBC component. Now, should be withholding enteral feeding be used in preterm neonate receiving PRVC? So there are temporal association of transfusion and development of NAC, labeled as the transfusion associated NAC. The multiple observational studies were done, and there was lack of designed RCT and paucity of data. And so, though the guidelines suggest that the enteral feeding should be withheld for 3 hours prior to and until end of the PRVC transfusion in preterm neonates, but because of the lack of the data, and this is not followed in the most of the unit, and stop feeding during transfusion is debatable and need further studies. So now coming to the monitoring and documentation are very important component of transfusion in preterm, and one should monitor temperature, SpO2, heart rate, input output charting every half hourly, and monitoring the vitals during transfusion is done frequently and aggressively in very sick babies, and the monitoring should be continued post transfusion for 2 to 4 hours. Coming to the strategy to make, we all have been learning in the NRP, the delayed cord clamping. The cord should be clamped at least 1 minute, and we should try to reduce the phlebotomy losses, and enteral iron supplementation at the rate of 2 to 4 milligram per kg should be given. We should use the micro container for lab testing, And there should be the effective phototherapy. Now, the phototherapy is very effective, LED phototherapy. That's why the incidence of this transfusion is decreased. And use cord blood for, we must use the cord blood for initial blood testing. And there must be the practice of clustering sample. So key point on PRBCs are no benefit of liberal PRBC transfusion over the restrictive transfusion strategy. So restrictive transfusion is the transfusion at very low level and less frequent transfusion. The most infant can be managed by restrictive strategy, and one should consider gestational age, weight, and respiratory morbidity while considering transfusion of PRBC. The next component commonly used by the neonatologist is the platelets. So now let us discuss about the guideline for use of the platelets transfusion. Platelets is available as concentrate from single donor or multiple donor. The platelets has very short shelf life and are stored under the constant agitation at 20 to 24 degrees centigrade. There is no effective preservative solution, and it loses potency very quickly and should be best used when it is fresh. Group identical or compatible ABO phenotype, but no RH matching, and depleted CMV seronegative platelets should be used. These are the differences, certain differences between the RDP, random donor platelets, and single donor platelets. This single donor platelets is definitely better. One unit has more platelets. It is costly, and single exposure decreases risk of infection, decrease risk of transfusion reaction. So this is definitely better. The most of center, however, is using this one because of the availability. Now coming to the platelet thresholds. So this is the recent Planet 2 randomized trial platelet transfusion threshold in neonate. This trial compare the low threshold, that is less than 25,000 versus the high threshold, that is more than 50,000, less than 50,000 prophylactic platelet transfusion on composite outcome of death and major bleeding. And the study showed that there was an increased death and major bleeding in higher threshold, that is less than 50,000 and not in the less than 20,000. As you can see here in this study, the threshold 25 to 25 versus the 50,000, and found there was no difference in the outcome. Rather, the more in the higher death and mortality was more in the higher threshold group, that is 50,000 groups. Hence, one should be restrictive in transfusion of platelets unless baby is bleeding or posted for the surgery. So considering the Planet trials, we discussed the recommended guideline by BCSH, as you can see, is the less than 50,000 for neonate with no bleeding. So we should not transfuse above 25,000 if the baby is not bleeding. And including the neonate with NATE, if no bleeding or no family history of ICH is there. Less than 50,000, if the baby in neonate with bleeding, having bleeding, there is evidence of coagulopathy or before surgery, or baby with NET if previously affected siblings with ICH. And less than 1,000 is considered when there is major bleeding, like significant IBH or major surgery. And same has been recommended by an NFCPG guideline also. So how much platelets to be transfused? This is 10 to 20 ml per kg at a rate of 10 to 20 ml per kg per hour. So it should be very fast and immediately as soon as we receive the platelets. So some of the practical tips on platelets. So start immediately after arrival of the platelets in NICU. And platelets concentrate must not be stored in the refrigerator. It should be kept in the room temperature. This is very important. A specific venous line must be used for the infusion, and it should be transfused within 1 minute. These are the some of the smaller study that warranted the large planet trials. And so which blood group? So we all know that the platelets express only the intrinsic ABO antigen, but not the RH antigen. So it is preferable to have ABO compatible platelets as far as possible. So the key points on platelets are there is insufficient evidence to correlate between the platelets count and the bleeding. And the low threshold, that is less than 25,000, should be used for prophylactic platelet transfusion in newborn. After platelets, the most commonly we use in NICU is FFP. So now let us see what are the indication for FFP. This is used to correct the coagulopathy in clinically ill infant having PT or PTT more than two times normal for age, DIC, vitamin K deficiency associated bleeding, and prior to invasive procedure with a risk of significant bleeding and abnormal coagulation profile. And this is very important that FFP should not be used in certain conditions like prevention of IVF, volume replacement, management of sepsis, as an adjunct in the management of thrombocytopenia, or to correct the prolonged indices of the coagulation. And the same has been also endorsed by the NNFCPG guideline. These are the certain systemic review and meta-analysis that also support not to use FFP for IVH and volume replacement. So key point on FFP are the use plasma of FFP when active bleeding is present or before invasive procedure in those neonate with risk of significant bleeding and who have abnormal coagulation profile. Similarly, the indication for cryo it is the most practical source of fibrinogen or factor 13 for neonate until a specific diagnosis is made, and it is useful in infant who require higher concentration of the factor 13, 8, W or fibrinogen. Volume of cryoprecipitate to be transfused is 5 to 10 ml per kg at a rate of 10 to 20 milligram per kg per hour. And 1 to 2 units per 10 kg is usually required. So to conclude, use only the component and avoid the whole blood unless it is indicated. Always look at the baby and not any abnormal lab values. Follow a standard guideline and be restrictive while using the blood component. Always monitor for adverse reaction as all blood products are akin to the drugs, and the follow-up response, both clinical and hematological, should be monitored. So thank you. Thank you, Dr. Ajay. Ajay? Dr. Bipul? Dr. Bipul? I think I have lost the connection. Is there any questions?
Sir, just wait, they are coming.
Okay. So I have finished. Dr. Ajay? Dr. Bipul?
Huh.
Huh.
Hello.
So thank you, Dr. Ajay.
We'll just look for the questions if there are any questions. There are not much questions. If we have any questions.
Okay, thank you.
उसमें नहीं नहीं है वो सिर्फ फुल स्क्रीन करने के लिए डॉक्टर ललन प्लीज स्टॉप शेयरिंग योर स्क्रीन so I think Dr. Lalan, we don't have any much questions.
Thank you.
Request now Dr. Jagdish Chandra sir to please join us on the stage. Just a few comments and then we'll start the.
So, good morning, everyone. Today was the last session of this series of lectures in the certificate course of hematology. And in several of the hematological disorders, one needs to think of
Volume thoda bada.
giving transfusions.
Abhi thoda
So, rightly, this topic was kept as the blood component therapy in newborns and children, and which Dr. Lalan Bharti has very nicely deliberated on very important points. And very, as in the end, he highlighted that it's the component therapy which is required, not the whole blood. There are very, very few indications, and very rare indications currently of the whole blood transfusion. One has to be careful regarding the transfusion, and only when it is indicated and cannot manage without the effect that transfusion of blood transfusion component transfusion also. I think
Thank you, sir. Now, I would like to introduce all the faculty to all of you. I request all the faculty members please come on the stage. Dr. Vipul, please join. Ma'am, projector. Ma'am, I think right. Ma'am, please. So good morning, dear friends. Thank you for joining this course. I hope you all benefited from this course. Was it useful, beneficial? And for this, we are thankful to our esteemed faculty who worked really hard to make all the presentations and spare their time on Sundays. And I'd like to introduce one by one. So we have Dr. Jagdish Chandra sir. He is my mentor and we are director at Lady Harding Medical College. So he is the main course coordinator. He supervises everything. We are really thankful to him. And we have Dr. Amita Mahajan, consultant at Apollo Hospital. Dr. Manas Chawla at Ganaram Hospital. Dr. Puneet Sahi. Dr. Mukesh Dhankar, he is Kalavati Children's Hospital. Dr. Kamaljeet Kaur. Ma'am, please join. Dr. Puneet Sahi, Dr. Pyali Mandal. Dr. Pyali Mandal is again at Kalavati Children's Hospital. So they work very hard to make all the presentations, and all these presentations are available on YouTube. We have shared the link. If any link is still left, you can go to IP Delhi channel and on the YouTube search just for the IP Delhi and go to the live channel part. You will have all the presentations present over there. So you can watch them again at any time. And I request Dr. Jagdish Chandra again to please address the gathering.
Well, I think this 4 months period had been really very interesting as far as the hematology, pediatric hematology and dissemination of its knowledge is concerned. And for this, the IAP, particularly the two persons who conceived the course, I should say, Dr. Ajay Gupta and Dr. Vipul Jain, it was basically their brainchild that that we should do some online training course, and actually we did not mix the hematology oncology, because oncology we felt that there's a very different subject from the benign hematology, and for practicing pediatricians it is not that you would need an in-depth knowledge of that, but we included in this the emergency management of malignant disorders whenever they come with malignancies, the emergencies, and also how not to miss cancer. So these two topics from the oncology side were included, and rest we included most of the things like deficiency anemias, hemolytic anemias, and the bleeding disorders, thrombotic disorders, and everything. So it was a very good the collection of topics, and as Dr. Ajay mentioned, that these talks are available on YouTube. So other than the persons who conceived this program, I must thank the faculty members who spared their time, and on our request they became available to do the talks, and whether it was a very short notice, because in the beginning for the persons who did the initial talks, it was a very short notice of 2 to 3 weeks only, but they are master of their topics and they did wonderful job, and you can see that the videos are being viewed by several thousand of viewers in the YouTube channels. So, and success of course depends upon the participation of the delegates, and it was really interesting to see that some 400 registrations, 475, so just touching 500, and that's a huge number. One again, I think we should give a very round of applause for this. So, okay, yeah, so that's nice, and I think this organization of this course also will pave a path for other the people who are interested in other subspecialties of pediatrics, maybe the respiratory medicine, where in pediatric practice you come across a lot of respiratory cases with infections, with asthma and several other things. So maybe this will become a routine with the
the Delhi IEP. So once again, a huge thanks to Dr. Ajay Gupta and Dr. Vipul Jain and all the faculty members and of course the delegates. Thank you.
Now I request Dr. Piyush Sharma and Dr. Mukesh Dante to begin with the panel discussions. So I request them to please call out the faculty for the different panels. And I request all the faculty members to please, Dr. Jagdish and Dr. Manas, please stay here.
So the first, good morning to one and all. It's my pleasure to invite the panel discussion, first panel discussion for today. The topic is judicious use of blood component therapy in newborns. So for this, we would have Dr. Vipul Jain, Dr. Ajay Kumar Gupta, and Dr. Lanan Bharti, who would be online for this session. And of course, Chandra sir and Dr. Manas is also there for this particular session. So I open this panel discussion, first panel discussion for the day today. Questions? Hey? Second say? Okay. So we will start with the second one, the anemia, second panel discussion on anemia. For that, we have our respected sir, Dr. Jagdish Chandra sir, and Dr. Manas Kalra for the same. So this session is now open for questions and answers.
So, if there are any questions, you can ask, and we would try sorting out the issues if there are any.
So please feel free to discuss. There is nothing like we don't know or we know and we have heard it and we should not be knowing it. So we are still learning. I'm still learning. I opened that IAP guidelines on anemia and I realized I don't know so many things. So, it is a learning process for all of us. Please feel free to ask questions. And if you don't have any questions or the questions will come in, say, like 5 minutes, 10 minutes, when you get a little warmed up, we have a few questions ready. So, maybe I can give those questions to Dr. Mukesh and Dr. Mukesh can ask those questions and, we can take this discussion.
That would be better. And no questions are small. Please be free to ask. Can I start one question, sir?
As all we know, government's anemia Abhiyan has started and we are giving this bi-weekly iron to all age groups. Means from 6 months onward to all adolescent in all age groups now, we have give the bi-weekly iron to all age groups from 6 months onward now.
Now,
whether the child is anemic or not now, it means we have to supplement all age groups. Instead of its iron status or its hemoglobin status, now we have supplement. It states that only. I want to clear this thing only.
Yeah, actually, that is the national program of iron prophylaxis.
Yeah.
See, this dose is kept as a prophylactic dose, not as a therapeutic dose.
Yeah.
And here in public health programs, what happens is that you do not look at the investigations all the time. And as it is meant for the preventing the anemia, right? So your question is that if the patient is not anemic, should I give it or not? Now that situation, like if you have already checked because of something that this child is not having anemia, you did hemoglobin or CBC, and you found that. But when the program is running, there is no harm in continuing with that prophylaxis. Okay. Though there are detractors of this, that if the patients are having, say, in public there would be 3 to 4% who would be having beta thalassemia trait, but as a national program, these things are immaterial as far as preventing the iron deficiency anemia is concerned. Yes, Dr. Tulika. Can we have the mic?
So I just wanted to add a comment to that. You can be iron deficient and not have anemia, right? So in India, especially for the public health programs, as you rightly said, the twice a week dose of iron is basically to prevent anemia. So even if somebody is not anemic, they could still be iron deficient. So it is perfectly fine. The only thing is, obviously, there will be some thalassemia intermedia patients or other patients, but again, these patients will be presenting to doctors at some point or the other, and the prophylactic dose of iron is not going to cause a problem. There's been similar arguments about iron fortification for this. But again, in iron fortification also, the amount of iron given is about the same as you would get from a normal iron-rich diet. So it is not going to contribute to iron overload. And in a country where we have 50-60% anemia, I think as a public health program, it is perfectly fine. You are not wrong if you give somebody with a normal hemoglobin prophylactic doses of iron.
And just to add to that, thalassemia minor can very well be iron deficient. So please remember this. This is the common myth that thalassemia hai to iron nahi dena. Please remember that thalassemia minor, 70% of Indian population is iron deficient. Even thalassemia minor will be iron deficient. So give iron to them.
And in fact, in my talks, I always emphasize that when you give treatment for iron deficiency, do not just stop at correcting the hemoglobin and continuing for replenishment of stores. Please attach all these cases to the national programs, whether it is the Anganwadi worker or from whatever source they are getting, in the schools they are getting the weekly iron folate supplementation of the adolescents. So that should be adhered to. Thank you.
And iron absorption is very well regulated with hepcidin and many other enzymes. So the body itself, if it is iron replete, it will not take the additional iron. So in a normal person, you're not going to have any problem.
Just a comment on what Sir and Madam has said. So if the child is iron deficient, not manifesting as anemia, the growth of the brain could be hampered. So it is wise to give iron, prophylactic iron.
Just one other comment, that the Anemia Mukt Bharat, or the National Iron Deficiency Anemia Prophylaxis Program, I mean, it is an amazing program, but unfortunately, a recent ICMR study showed that only 1% of children in the 6 months to 19-year category are actually receiving that supplementation, which is 100 days a week, 100 days a year of iron supplementation. So I think the onus falls on all of us when we see them in our practice to see that they are getting that supplementation. They may or may not be anemic, they may or may not have a hemoglobin, but that they should be receiving, and we should not assume that they are getting in school, because by and large, due to various logistic issues, that is the ICMR data. So I think we all, whoever we see, we should be recommending that.
Problem is they are not getting in and supplying, and the problem
I think these things we have to just constantly persist and keep sending communication. I am sure if you persist, you will get it. There is that iron is there, it is getting expired. It's just, it's not that high a priority. मैम आप चिट्ठी लिखते रहो, आएगी जरूर आएगी.
I will convey your regards to concerns to Dr. Vannam Durga, who is the Director Family Welfare.
Logistics.
Yeah, one thing here, when we see patients, when we see admitted patients or OPD patients, I personally ask them whether ASHA worker is visiting them or not, because this is actually supposed to be going through that channel. And they do say that ASHA worker is coming, but not talking about iron
And when Asha person gets admitted with her child, I talk to her, what are you doing? So you have to make the patients aware that there is a person who is coming to your home, whether she is giving iron or not, and what is happening, to raise the parents' awareness in the meantime. So then when everybody is aware, then it becomes a norm here.
Yes, sir. No. Dr. Vanna Patel is again a pediatrician who is the director of family welfare. So any concerns can be easily raised. MTD. So we also welcome Dr. Tulika Seth, ma'am. She is the professor of pediatrics at AIMS, and Dr. Nita Radhakrishnan, director at multi-specialty Children's Hospital at Noida.
So, sir, just can I add? Just please go ahead.
So one question: if RBC count is high, despite anemia, then thal minor is to be considered. Any other DD we are supposed to consider along with it? Just thal minor, or we have to consider other diagnosis?
The commonest situation would be thalassemia minor in our country.
Any other?
So you calculate, if it is a mild anemia, just calculate a Menzer index. It will give you a rough idea of what it is. A high RBC count, usually erythrocytosis, polycythemia, and all those conditions you can have. But with anemia, usually you will have low RBC count in most of the conditions.
Thank you.
So it will be like iron deficiency situation. So I think it will be, if there is a lot of iron deficiency, then the RBC count will usually be low. I don't know, sir, what do you?
Would be low.
So, sir, basic, just to carry on this message, what are the basic tests in our poor erythrocytic conditions? What we should basic test just?
So, sir, basic test for iron deficiency anemia is a CBC and a peripheral smear. I think that is the most important test. Let me complete. So based on the first investigation on a CBC peripheral smear general history, you can make a diagnosis of iron deficiency. It is not very difficult. You will have a low MCV, low MCH, low MCHC, high RDW, low RBC count. So all this will point towards iron deficiency. You have examined the child. There is no splenomegaly, nothing. And, the history is that of a milk-based diet or just a normal, Indian diet generally is iron deficient. So with that, you can very well suspect iron deficiency. Ideally, yes, we would like ferritin, iron studies to be done. A minimum basic, if you want one investigation, the best investigation is serum ferritin, especially if the child is not febrile, not having any active infection. One serum ferritin and a CBC peripheral smear is enough. Now, if you want to go into detailed investigations, you can do all the iron studies, you can do serum ferritin. There are many newer parameters also, but I don't think on a routine basis, those are required. And the cutoffs are very, very clearly laid. So, even the IAP guidelines have given, cutoffs for ferritin. So please follow that. Bedside ways of MCV calculation have also been given in the guidelines. So you can follow that. And if you have any questions regarding that, please feel free to ask. So less than 12, less than 15 is the general cutoff for ferritin, and less than 30 in a febrile state is what has been recommended. But, during fever, ferritin is not reliable. We all should know that.
Dr. Manas, at times it's a very common situation in our clinic that a child is coming with a hemoglobin, borderline hemoglobin of like 5.5, 6, and the child is not, we are not.
So 5.56 is severe anemia.
Yes.
Yeah.
Whether at what point we should give BT, or patient is not ready to get admitted, or like.
So in a hemodynamically stable child, there is no need of giving blood transfusion. You can just manage them with oral iron, oral B12, injectable B12 if there is B12 deficiency and you have severe anemia. All these options are available. Oral B12 is also pretty good. So if you have a megaloblastic anemia like situation with a hemoglobin of 5, I would just give vitamin B12 and you will not need blood transfusion. Blood transfusion is for children who are hemodynamically unstable. You have features of CCF or the child is very unwell due to some other condition and is very sick in the hospital. You want to give blood transfusion. Pre-operatively, some emergency surgery has to be done. You want to give blood transfusion. So those would be the situations. In a small subset, there will also be a scenario where you can give IV iron to raise the hemoglobin rather quickly, because you want to avoid blood transfusion for patients. But I think by and large, most of the patients you can manage with oral iron, oral B12, or injectable B12.
And the same child is admitted in the hospital, like severe gastroenteritis or CRP is raised, CLC is raised.
So you look at the clinical condition of the child. If he's sick, please give him blood transfusion. At that time, you don't want to give IV iron, you don't want to give oral iron, and the child is sick, purging like anything. There is a chance that this child may go into ICU. You want to hemodynamically stabilize this child, I would give blood transfusion to that patient.
Right. Thank you. So,
definitely. So that is a different discussion. Iron deficiency is so common in India, and most of the children will be managing with iron. There will be children where you will have some other telltale signs of, some other problem, like a history of recurrent diarrhea, some clubbing is there, some hepatosplenomegaly is there, failure to thrive is there, short stature is there. Obviously you will be evaluating them. But if it is clinically looking like a pure iron deficiency, nutritional anemia, treat like a nutritional anemia. Now keep this child on follow-up, look at the hemoglobin level, look at the expected rise, look at, recurrent falls and, some other symptoms appearing, and evaluate this child for other disorders. If a child has failure to thrive, severe failure to thrive, upfront also you might want to evaluate for CKD, for iron deficiency and other parameters, and there will be some subtle differences in the iron parameters in between all these conditions.
So Dr. Manas? Yes. So regarding the preparation of iron salts, there are various salts available. So in terms of palatability and adherence to the therapy, which is the best salt which we can prescribe? And please specifically comment on the colloidal iron also.
Well, of the various salts available, the fumarate, gluconate, and the ferrous sulfate. These are the three salts which are recommended for oral use. That is number one. Second, the ferrous sulfate is not a very good drug given in liquid form. And I do not recall many preparations with the ferrous sulfate being in the liquid form. Mostly they would have gluconate or fumarate. So these are the two preparations which are equally effective as is ferrous sulfate, and these are the ones which are recommended. Colloidal iron is slightly expensive, but it is effective. It is an effective therapy and that can be used. So when we decide to treat with oral iron therapy, you would realize that, say, a child with 7-8 grams would normalize his hemoglobin to 11, 12, 13, whatever according to the age, in say about 3 months, right? Another 3 months or 2.5 to 3 months you need for replenishment of store. So a good 5 to 6 months therapy is required. Now the cost becomes a factor. And the colloidal iron preparations compared to these gluconate and fumarate preparations, they are little expensive. And same, I would also say that there are ascorbate preparations. They are even more expensive compared to even colloidal iron. But then these are the drugs which can be used in cases where the drugs which I mentioned earlier, the first line, they are either not being tolerated well or they are leading to some side effects. You can use those drugs. Okay. I hope I have made the thing clear. Yeah. So in my private practice, because I work in a private hospital, most of my patients I use ascorbate or fumarate, and I've discussed this with sir because in the guidelines the ascorbate has not been mentioned in a prominent way, but sir was very clear in explaining to me that the
studies, the volume of studies and the amount of literature on that is very limited. With my personal experience, it is 160, 170 rupees bottle for a ascorbate syrup. It is kind of very well tolerated, and iron deficiency anemia can be very well treated. So you can choose your patient, you can choose your the financial status of the patient, their affordability. It's a 6-month therapy, so you can make a choice from all the products that are available. So Feronia, Orofer, Vitcofol, these are some common preparations which have got ascorbate or fumarate, and then the government provides ferrous sulfate in the nutritional anemia program.
Sometimes the MR claims will help it better.
Actually, the latest on vitamin C is that additional separate vitamin C is not required. It is not beneficial. But ascorbate group also says that this is better because there is ascorbic acid in this, but it doesn't have a much. In fact, there are several bodies in the world literature where they write about the iron deficiency, say gastroenterology, adult gastroenterology, adult renal this thing, and there are guidelines, and they all recommend that ascorbic acid does not add to the benefit of giving oral iron therapy.
Same situation with health combination.
I think just one thing to add for what not to give, and something like we are in a room where there are no midlets. So Taziran, which is heavily marketed, is actually completely useless. It is even not sanctioned by FDA as a iron supplement. It is sanctioned as a dietary supplement that you could take. Maybe it can maintain your hemoglobin. It's Taziran, very expensive. So many of the more expensive variations which have these additional things are actually, according to the Drug Controller Authority, not even approved. Other than folic acid, anything else that is there is either inadequate quantity or it is actually interfering with iron absorption like calcium. It makes no sense to add calcium to a iron preparation. So I think the simpler, older one, we are all used to tonoferon. It's not a perfect preparation. It is okay, but it has its own problems. But just be careful that tonoferon adult syrup, because when we write tonoferon and we've not written pediatric, it is 250 mg per 5 ml. And the commonest cause of acute iron toxicity in India. Orofer and Orofer XT. Orofer is a polymaltose, Orofer XT is ferrous ascorbate. So I think our minimal, how we write and how a busy pharmacist may pick a preparation and give, may be the reason why we sometimes don't see the response that we are seeing.
Thank you.
It is so heavily marketed. The Taziran is so heavily marketed, and the medreps will keep standing outside your. We are live on YouTube. Request all the faculty not to take brand names. It can be age. So I think the message is very clear, and we can move on to the next question. Just an extension to the previous discussion. We get almost 3 to 4 babies every month to come to us with the hemoglobin less than 3, coming to us with 2.5, 2.2. We know it's nutritional anemia. How persistent should we to ask them for a regular follow-up? When should we call them for regular follow-up? So we generally call them after a week to repeat hemoglobin. And what other advices should we give when to come for routine for emergency visit to the hospital? What should be our advice to those children?
So do you mean that a child with 3 gram or this hemoglobin you have not transfused?
Not transfused, sir. Chronic anemias, nutritional anemias, we send them home, sir. We send them home at 2.5 also. We've sent
Well, I think that is being too bold. not to give transfusion at say 3 or maybe lower than that. The cutoffs described are 4 and 6. Below 4 mostly. In occasional case, I also might not have given transfusion, say at 3.5 or 3 also. But then one should be sure that they are coming for follow-up. Now, your question is very interesting, that what we should advise for the follow-up. You have to ensure the follow-up, whatever way you advise. one thing is that you could impress upon the parents that the iron deficiency will lead to continued iron deficiency will lead to impairment of his intellect and overall development growth. So that probably will hit them, and that would make them realize that the follow-up is really important. So otherwise, if the follow-up cannot be ensured, I think there is no shortcut. You have to give transfusion.
Once we've ensured follow-up, children generally do come back, sir, when we tell them it's very high risk and we are trying to avoid transfusion.
And then you ensure that there is a response. Okay.
What precautions should we tell them to take at home, and when should we visit?
Well, see, the balance could tilt the other way is because of infection. So in case of any infection, in the first visit after prescribing iron in the first visit, what we expect is that you have seen that the patient is compliant to the drug, number one. Number two, the patient is tolerating the drug. Okay. And when to return immediately is that whenever there are infections, say if there is diarrhea or he has got some, say, respiratory infection, that would probably impair the absorption. And if it is bacterial infection, it would harm also. So in that case, they should immediately come to you. Okay? Yeah.
So I think the panel has excellently described the medical management, but you have to remember iron deficiency is basically a nutritional deficiency. And we haven't talked about dietary counseling. And it's really important as pediatricians to be well aware and to give dietary counseling in a practical way. Simply telling the mother ki palak de de and things is not enough. You have to give dietary counseling which is age appropriate and which is culturally appropriate, so that these families who have got these nutritional deficiencies can correct this, because we don't want the child to be on supplementation for life. The supplementation is for a short period of time because of the extreme deficiency. But if you have a very good, healthy, balanced diet, you can prevent this. There's an excellent book that most of you must have read in your PSM, Dr. Gopalan's Nutritive Value of Indian Foodstuffs. That is a fantastic book. Each time I read it, I learn more and more factors, and you can give dietary counseling and have patients have a better diet without any extra money whatsoever. So, for example, we all eat cauliflower. Cauliflower has hardly any iron, but if you add in the cauliflower leaves have as much iron as beetroot. So simply with, you buy the cauliflower, just cut the whole thing into the vegetable. So you can advise your poorer families who can't afford very, fancy foods, that they can do that. Things like pomegranate are not containing a large amount of iron, right? A lot of families think that you have to buy expensive foods or other things. It is not there. So give good practical advice so that the families can not have iron deficiency in the future.
Just one point to add to what ma'am said. So I think reducing milk is the best thing. First, when they come to you for the first time itself, you have to harp on that point that milk has to be reduced, because majority, 99% of patients who come to you with iron deficiency are just milk overfed babies. And when we stop treatment, as Vishar said, that we go back to the national program, that is not practical. Majority of them do not get any access to national program in their homes. So either we continue the same drug, whatever we're giving daily, you can continue on Saturday, Sunday basis. So then there is something which goes on regularly. So if you give 2 times in a week, still you are getting 100 days per year. So that still is something similar to the national program, and the family knows that they need to continue the drug. One. And second, they're going back to the same family pot feeding. However, we actually counsel, their cultural differences, their family taste, etc., does not change. So reducing milk, if we really insist on that point, I think to a great extent we can improve the overall iron status. And 2 fruits per day, if we can tell them, that might be a lot of other things also, like constipation and all, also improve.
At times it becomes very difficult. You want to say something? Yeah, please.
Good morning, faculty. I'm Dr. Jolly from Assam Medical College, Dibrugarh. Sir, I just from my experience, I want to say, like, some patients we are getting there, even with hemoglobin 8 and 9, like with mild respiratory infection, So they're coming with SpO2, very low SpO2. Suppose we need to put them on sometimes CPAP or NIV, and after correction of respiratory infection part also, the respiratory distress doesn't go until and unless like recently we have seen that most of them we need to transfuse them. So there is my question. Like sometimes at 9 hemoglobin or 10 hemoglobin, there is no indications for transfusion. But after 1 minute of transfusion also PCV, so this respiratory distress it turns better. So what way to say, like our students they used to ask like, madam, why
patients with mild respiratory distress should not require transfusion at 8 or 9
not mild. We are putting in CPAP.
If you are not even CPAP, if you are putting on really ventilation, in that case the hemoglobin has to be above 10. So in that case you have to give transfusion.
Yes, as a ventilator.
Yeah, that has to be an individual decision. It's not strictly that we are trying to minimize, but we are not against giving the component therapy. There are indications, and particularly intensive care receiving patients, and they are intensive care because they have some problems, isn't it? And if the respiratory problem is such that which is requiring ventilation, then certainly it has to be above 10 grams.
In fact,
the
intensive care guidelines are also now moving towards a conservative transfusion approach and not an over transfusion approach. So I think look for some other causes, and maybe your treatment or your ventilation only is, kind of improving the status of the child, and the credit is going to the transfusion. So I think, this needs to be looked at again. Conservative transfusion is what I think most of the intensive care units would now follow.
And another question, sir, we are getting few cases like around 10 years, 11 years child, they are coming with anemia with neutropenia. And on evaluation, anemia, there comes like picture with the MCV also in normal range, but while doing the TC like in below 4,000, and platelet counts like around 95,000, 90,000, like in the trends they used to come. So what may be the causes? So we are putting them on the nutritional anemia level because this serum ferritin level, they are also coming normal. But the counts are like 3,000 patients are coming like some mild to moderate symptoms.
When you talk of pancytopenia, iron deficiency, anemia, and ferritin is not the most important thing. Pancytopenia with high ferritin, you may think of HLH. Pancytopenia with normal ferritin, you need to evaluate the causes of pancytopenia, which in many cases can just be a viral infection. A viral infection led bone marrow suppression, which is transient, which would recover with time. Rule out B12 deficiency, because B12 folic acid can also lead to pancytopenia, but your symptom complex of infection, cytopenia, recovery sounds more like a viral infection, and most of the times we'll not have an answer for that because we don't have access to biofire and the ability to do it all the time, because it is an 18,000 rupees test, or do viral PCRs can be little difficult, So yes, so we also don't do it. And if the trend is that of an improvement, we definitely look at the peripheral smear. Sometimes you can see some atypical lymphocytes that will point towards a viral infection. So I think there are some soft signs, and very categorically to say what virus it is can be little difficult.
Is it again?
So bone marrow picture was saying other erythroid series in hyperactive, and your eosinophil counts are high. So only that was a suggestive findings. In 2 cases we got that. So we had just think
for the etiology of this, like what is the cause of eosinophilia in such case, isn't it? If there are respiratory infection, one has to look at If it
No,
is
child even has
Borrelia
no history of
bronchiolitis,
fever even. They come
yeah.
for only
So,
giddiness
I mean,
and
these
anemia.
just can't be on the basis of nutrition anemia. You can't explain these things. There has to be, say, worm infestation could be there. The pulmonary eosinophilia could be there. Several causes of eosinophilia which are there, and any food allergies, etc., which are associated, that might be leading to the eosinophilia. One has to evaluate what is the cause. It does cause. It does cause. Bone marrow, obviously, if nobody does bone marrow evaluation in helminthiasis, but if the eosinophils are increasing, obviously the precursors would be more in the marrow. I mean, that is a logical thinking, isn't it?
Coming to your earlier question about like having neutropenias, thrombocytopenias. So if you look at the RDW, it might be raised and your MCV may be. It could be because of like dimorphic. So patient may have coexistent iron as well as B12 deficiency and your MCV looks okay. So it could still be the RDW.
So good morning, all of you. So my question is regarding the refractory iron deficiency stage. So in a child, we have all the clinical as well as the investigatory picture of microcytic hypochromic anemia with low serum ferritin. And the child was started on iron therapy. He responded initially clinically, but he had then relapse or the recurrence of symptoms along with the same hemoglobin falling down. No other evidence of iron loss from any side. So how do we proceed for that child?
You are, where are you working?
Sir, I'm working at PGIMS Rohtak, Medical College, Rohtak.
As?
As faculty, sir.
Okay, so, sorry, I didn't know you. So, what all was done for this child?
Sir, we investigated for any cell intermedia like states, we have done the HPLC was normal, parents are also fine. So any losses from the GI, like we look for any blood, occult blood in the stool or.
How long the therapy was given?
So the child had received a 3 to 4 month course initially. Then after some time, like after 6 to 7 months, he came back again with the hemoglobin of around 5 or 6. So initially when the treatment was started was at the same level 5 grams, and after he becomes like 9 to 10, he didn't come back for the follow-up, and after 8 months he came back again with the anemia.
So 2 times you have shown response to the iron therapy, oral iron therapy, is it?
Yes.
Yeah, so which means that the iron absorption from the gut is fine. It is in fact improving the hemoglobin status, and that means iron status is also being improved. Now, these are the situations where one should check the ferritin levels after the correction of anemia,
yes,
if that has become normal or not. Now, mostly such cases would be either you have not been able to replenish the stores because the duration maybe it was less, and again he goes to the diet which was, like Dr. Neeta said, the diet from the family pot which is deficient. But then the recurrent blood loss should be looked at.
Yes. So that is my question. So whether we have to repeat this serum ferritin at the end of therapy?
It's not usually, see, there are recommendations on whether to do it or not. We felt that this is not required in all cases, but situation like this, where you are saying that after correction it got, recurrence of anemia and then improved. So at the end of the therapy, in such cases, you should check whether ferritin is normal or not.
At readmission, he again had this low serum ferritin, so that's what I'm asking.
Which means iron deficiency is occurring again. Yes. And then in that case, either the dietary problem is there or there is a blood loss. Right. So one has to look at the blood. In celiac disease, it might have improved, but then you can look at the celiac disease parameters as well due to serology, and look at the blood loss, maybe intestinal blood loss. If it is, you can do the occult stool blood and look for the causes and do the. How old is the child? You said
9 years. 9 years.
And maybe gut GI is the most this thing likely cause where like system where the blood loss is occurring, and you can do those isotope studies to see if this is makers, right? So in such cases, these studies are required. It is clearly iron deficiency anemia which is recurring.
Yes.
Right, recurrence is either you are giving diet which is poor again, you are making him deficient, or he is leaving somewhere. If there are pulmonary symptoms, then you can think of what is that called, pulmonary hemochromatosis. Yeah, but then that is in mostly younger children. So look at the inflammatory bowel disease where there is blood loss. The stool occur blood, maybe there are other tests for Crohn's disease and ulcerative colitis like disorders. You can do stool calprotectin, etc., and look at the causes there. Okay? It may be that it's not symptomatic at present. Maybe certain symptoms are there which is not being picked up or being told to you by the family. So the GI blood loss is the most likely thing that one has to look at.
Maybe a viral thing, and then the child initial episodes just improve with supportive care. It's only when the long-standing damage happens, then that hypoxia never recovers, and then you need to evaluate. By the time, it's usually too late. It's very, very rare that you pick it up in the early stages. So similar condition where you're having recurrence, so blood loss has to be investigated.
Pre-symptomatic or early symptoms which are not being told to you by the time, or they are ignoring you.
Good morning, sir. Sir, in iron deficiency anemia with THAL intermedia, does the iron deficiency anemia mask the HPLC report? Because recently we came across a case of a borderline anemia, around 10 or so HB, and microcytic hypochromic, the Menzer index was 10. And RBC count was on the slightly on the upper range, around 4.5 or 4.8 sort of.
So thalassemia intermedia is an iron excess state, not an iron deficient state.
But
they usually will not have low ferritin. They will not. They will have microcytosis. They will have high RDW. Their peripheral smear will show evidence of like a thalassemic state with nucleated RBCs, target. Intermediate. She said intermediate.
Minor or intermediate, maybe.
No, minor and intermediate are two very different things. So thalassemia minor with iron deficiency is a very common situation. See, 70% of Indians are iron deficient. Then thalassemia minor will also be iron deficient. So that is a different situation altogether. In a thalassemia minor, pure thalassemia minor, what will you see? You will see a low MCV, a normal RDW, a high RBC count. This is a typical of a thalassemia minor. In iron deficiency, you will see low MCV, high RDW, and a low RBC count. Now, if both the things are together, you will see a low MCV, you will see a high RDW, maybe because of the iron deficiency, but the RBC count is disproportionately higher. So that is how you pick a thalassemia minor with iron deficiency. So do a HPLC, do a serum ferritin and iron study. You will know that there is iron deficiency with a raised HbA2. And when that is the situation, you know that you have to correct the iron deficiency in this situation, and HbA2 will always remain high in that patient because he has got thalassemia minor. Okay, so it can be a little confusing, but evaluating for both the things will give you the answer.
So like Menzer index was around 10, but it was less than 13. So, but when we did the HPLC came out.
So Menzer index has to be used only when there is mild anemia. Don't use Menzer index if there is moderate or severe anemia. Okay, Dr. Tulika is not waiting for a second. Yes, madam. I think one might see this item.
Sorry, I am impatient because the one point that is very important that I wanted to bring out of this is when you do an HPLC with iron deficiency, the iron deficiency makes your hemoglobin A2 low. So this is not the time to do an HPLC. treat the iron deficiency and then do it, because otherwise you may miss a thalassemia trait, which later, it's not going to affect the child's health that way, but in the future, the child will not know that they're a thalassemia trait, and they can, marry another thalassemia trait and then have hemoglobin hemoglobinopathy in the family. So very important to know that hemoglobin A2 is going to come down with iron deficiency, and that may be why this was normal. So correct the iron and repeat the HPL.
That is actually the correct clinical teaching. But if you have done a HPLC so many times, even with iron deficiency, you will find the thalassemia minor. We have found it so n number of times, thalassemia minor with iron deficiency. But ideally, it would be correct the iron deficiency and then do the HPLC of the patient.
Regarding RBC count being high in a suspected patient, right? So many a time, so we all know that in thalassemia minor, you will have anemia with disproportionately high RBC count. The other scenario is iron deficiency anemia. If the patient has started treatment outside, if somebody has given some iron preparation or some Ayurvedic preparation or something like that, even homeopathic medicines for iron deficiency, there is an increase in RBC count initially, even before your hemoglobin improves that much. So, in that scenario, maybe from 5, it has gone to 6, but the RBC count increases way more. So, in those scenarios, you may still find a higher RBC count in iron deficiency anemia if they have received some partial treatment outside.
Asking family history also adds. So always ask about the family history of gallbladder stones, any surgeries, any transfusions and jaundice. Always ask them. That also helps. Merely relying on investigation may not be wise all the time. So we have the very, very, very common question is
I think this is the most popular session, sir.
Yes.
This is the most practical issue.
This is the most practical one. We used to treat this iron deficiency with 6 milligram per kg, and recently we are doing it with 2 to 3. What is the rationale and what has gone behind?
Actually, it's very interesting. We made a IAP PHO chapter some 30 years ago. We never thought of writing about the deficiency anemia because we oncologized the whole chapter. Now, when we reviewed the literature last year, now I'm very clear on that. See, yeah, all right, yeah. See, you are seeing the difference. Just one article, but then just one article has made people aware of that iron deficiency anemia or other deficiency anemias are a real problem, and the way we are treating is not really correct. Now, coming back to the question 6 versus 3 or 2 to 3. One could argue that 2 to 3 is the preventive dose, but who knows whether that is correct or not. Now, let me tell you, the British guidelines, adult guidelines on treating iron deficiency, they say that start the treatment with 1 or 2 tablets of fersolate or the ferrous sulfate, and their tablet of the NHS, which supply is there in UK, that contains 63 and 62 milligram iron. So why a child should get 6 milligram per kg when the British adult would be 70, 75 kg? He is being prescribed 1 or 2 tablets. Even if 2, it is less than 2 milligram per kg. Right? That is one statement. Second is that there is a beautiful study, which I think 2017 publication, and he has shown improvement with 2 to 3 milligram per kg. There are not many studies on this. Unfortunately, from India, there is very little data on treatment of iron deficiency, and I think we cannot generate very easily because you do not have iron available. You have iron with folic acid. 95% of your preparations, because of the program, is iron folic acid. How will you show that one iron preparation is better than the other iron preparation? So either you have to go to the pharma industry and tell them that I want gluconate preparation, I want fumarate preparation, and placebo or the one controlled arm will get this and the other will get that, and show the difference. Same with the dosage. So if this 2 to 3 milligram has shown good response in almost 3 to 4 weeks, the hemoglobin rise was as good as with 5 to 6 milligram. And unfortunately, the Nelson still maintains that 5 to 6 milligram per day, which is this, we say that it is Bible, Gita, Quran of pediatrics. It is so unfortunate. But then that continues. And surprisingly, when I said that we did not bring out anything on deficiency anemias in our country, in the world literature, there is not a single pediatric guideline on treatment of iron deficiency. Not a single. And there are 40 odd guidelines for treating iron deficiency in adults. So that much neglected the pediatric component is. And there, what is happening is, I think in a couple of years, we will see in adult side that the iron deficiency has to be treated with IV iron. Why you want to trouble somebody for 6 months? Just give 6 visits to the hospital, IV push iron, that's it. In one visit also, see. So, and we have to see that pediatric treatment is different. And but it can't be as different as 1 milligram per kg for adult and 6 milligram per kg for the proportion of iron absorbed from the dose would be the same in pediatric, and it would be much better compared to. And in fact, there is another study which he has used, I think, just 30 milligram in patients who are 70 or 80-year-old, and he has shown improvement with just 30 milligram because they do not tolerate iron that well, the elderly people. So that small dose also works, right? So I think there is no reason why we should give, and you would avoid the adverse effect. So with giving 5 to 6 milligram, the adverse effect would be more because of unabsorbed component will get onto the colon where the bacterial proliferation will occur. It would lead to adverse effect, and that adverse effect will lead to poor compliance. So that is the reason why we should give 2 to 3 milligram per kg. And if there is no response with this, then please look at other causes rather than the dose being less.
So we can say it was by default, it was.
No, I think it is persisting, even in Nelson, it is persisting with that 5 to 6 milligram, it is still there.
But I think that dose is based on what proportion of iron we expect to be absorbed. But in our scenario, our iron dose was so difficult that the proportion of absorption is much higher. Because they are talking of iron deficiency, they are not talking of our kind of iron deficiency, which has virtually 1 to 2 ferritin and no iron stores. So the percentage of iron absorbed is 4 times that it would be in normal, hemostatic. With the same doses. So percentage absorption is. That's right. That's why a lesser dose will probably, and the unabsorbed, the side effects are largely due to the unabsorbed iron. And that is, that will decrease the compliance if they are more. And that's why we see that with the higher dose, they quite often stop. And just to highlight from the guideline that came out, that empty stomach versus postprandial, that empty stomach absorption may be a little higher, but postprandial side effects are much lower. In a deficient state, still you get adequate absorption, and there is much better compliance to that. So the current guidelines actually recommend single daily dose post-evening meal, because anything that you give first thing in the morning fasting state to a child going to school, the compliance will go down because there is so much happening at that time. So the first guideline, the guideline that has come out, has a very practical point on ensuring compliance.
So there's a.
In fact, 2 chapters of Indian Academy of Pediatrics have contributed to them, not only PHO, the nutrition chapter as well.
Right. Another important concept that has come out in treatment is alternate day therapy, and there's a lot of scientific basis on that relating to the iron absorption. So even if your patient is not able to take the daily recommended dose, you can give the same dose alternate days. So you don't need to increase the dose, you can give the same 2 to 3 milligrams on alternate days. And there's a lot of evidence backing that.
If you give a gap between your regular iron, then there is this concept of mucosal block, which helps So you are continuously giving iron, you have everything which is oversaturated with iron and your absorption will go down. If you give a gap in between, then with the mucosal block theory, you may have a better absorption. I think that is the logic of giving a gap of 1 or 2 days in between your regular iron therapy, which is practiced by some. So the basic story is that give iron. Even if you give minimal iron, give some iron, because that also will be absorbed, and hopefully we will have better percentage of, non-anemic patients in our country, which continues to hover around 60 to 70% in this population of young children, teenagers, adolescents, pregnant women, who are the high-risk population. And, the onus to a huge extent is for the PHO chapter, but also to all the pediatricians who are managing patients day in and day out. So give iron to your patients, and iron is going to change the anemia status of our country, will improve the IQ of people. We'll have many more Chandrayans going everywhere in the sky, which we are anyway sending. With 70% anemia.
I think with 20 to 80% prevalence of anemia, we should be in a habit of writing iron to any child more than 6 months of age, irrespective of the iron status. We must write. Even the maintenance dose. Some iron should be given.
Yeah, that's right. Just one comment on what just said about alternative. I think alternative therapy should be resorted to only if it is not being tolerated, because there's a very good study, recent one, I think 2020 publication from PGI Chandigarh. They looked at the hepcidin response to alternative therapy, and they then calculated that if you are giving the same dose, let us say over 2 months you are giving 30 doses rather than 60 doses, so the amount of drug given is half. And if you are looking at a faster response, then this would be inadequate. So this should be resorted to only if there are problems with even daily therapy. And with that mucosal block, there is that is one way of explaining the iron therapy not being given daily or maybe given at a large intervals. Again, on this single versus multiple doses in a day, that also is now currently being explained by the hepcidin response. Actually, there is a group of workers which have shown that if you give 2 doses of iron, say same dose in the morning and same dose in the evening, the fraction of the dose, the fraction of iron absorbed from the second dose is much less compared to the morning dose. Now they have used different isotopes, say Fe59 and Fe61 or something, and they have shown that that is on account of the hepcidin. The first dose leads to the hepcidin rise, and that interferes with the absorption from the second dose. So that is the rationale behind giving single dose, that is once a day dose. And mucosal block, of course, is there.
Any more questions? Was really please.
Questions are never going to finish.
we are more than happy to take. Please.
All the children visiting are okay. More than 6 months of age. But when the children visit only when they are sick. Either they are having gastroenteritis or they are running with fever. So we should be prescribing them also, right?
You have to take care of this.
Because usually in government hospitals, they don't follow up until and unless they are sick. They don't follow up.
But you can tell them to take it after the recovery. Yeah.
You can advise after recovery.
But still they don't start. Once they don't even complete their...
See, our responsibilities is in prescribing and explaining the rationale. We can't go and administer it to them. So do your job and hope for the best. If you keep on telling, they will start. Yeah. Sir, can I ask one last question, if that is allowed? I just want Dr. Chandra to comment on the B12 dosing by the guideline. I find it little difficult to stick to that guideline B12 recommendation, because the IM recommendation is rather rigorous. You give 25 microgram every day for a week IM, and then you go down on the doses. It is Okay. So I find that a little challenging and very rigorous, and to give intramuscular injection every day can be little difficult for a child. So, what is, just want that comment on that.
So are you trying to say that one could manage with oral? Is it? Or
So if you give high dose 1000 micrograms or 1500 micrograms.
let me tell you, this is already 1 year or maybe more. October it got published and we submitted it sometime in June last year, June or July. This one area was the treatment of B12 deficiency was one area when we were making these guidelines. They were not sort of very well information on this available, good information available on this. And the faculty said, I am doing this for last 20 years and I have no problem. There were statements like that, and they were all contrary to what one person was doing and the other person was doing. So, no practical problem. And in fact, the guide, whatever is there in the guideline is not what I actually do. So what I do is, in a say mild anemia with B12 deficiency, I do give oral iron, oral B12, and I have given a dose of 30 microgram per kg. Now there is a reason people said that no one else has given per kg dose, but then somebody has to start. So they will accept that when it comes from somewhere outside India. Maybe some Iranian journal will publish that it would be accepted because it is coming from somebody from India, though documented in a very good journal. This study was published in Pediatric Blood and Cancer, where the 30 microgram per kg dose had shown elevation of hemoglobin for something like 6 to 7 to some 10 plus. Though all cases did not normalize with that dose. So oral B12 does work well. The injectable, maybe IV or intramuscular, they should be resorted to if you want faster response. We sort of, I think that the guideline mentions that those who are having neurological or neurodevelopmental problems, they should be, or if there is severe or pancytopenia is there, then you give injectable. That is fairly good. Yeah.
Because IV gets removed very quickly. It's just that the daily recommendation is a little cumbersome, but sir says that you can have your own protocol.
Yeah, that's right. And after those guidelines, also there are a couple of studies on use of B12 injectable and oral published in, I think, in Indian Pediatrics itself, but they are also not very well designed studies. So I think we need to work on that and maybe collect more information, and then maybe guidelines are always open to revision, and people do revise after a couple of years also. So
oral preparations, are they available?
Yeah, I think we do give
isolated.
Methylcobalamin is available as I'm not taking the brand names, but
drops injectable is available.
Oral tablets are there. That study that we have done is oral. We use, for that study I can quote, we use Neurokind. Neurokind, methylcobalamin, 500 milligram tablet was used. That was crushed and given according to the per kg.
So the syrup was not.
No, that syrup Neurokind has several other things. Thiamine, etc., etc. But that Neurokind tablet has just methylcobalamin.
Because it's always with the combination of iron and all that. No?
So two syrups, definitely I know the name. Mecanerv Z and bifolate. Syrup.
Mecobal is there.
No, I'm telling syrup is there, tablet is also.
There are sublingual preparations are there. There are nasal preparations and. Yeah. Good response. And it would take away the problems related to absorption actually. Yeah, that's right. And another thing is that I think Dr. Vipul is sitting there. His thesis was on megaloblastic anemia. I started working on megaloblastic anemia when he was doing his thesis. And during that time, we had reviewed that in combination syrups, the bioavailability of B12 is very, very low, whether it is 9 or hydroxy, whatever. Yeah, yeah.
If anyone remembers that movie, Millie, Jai Bhaduri, Amitabh Bachchan, what the Millie had? Yes.
And she was flown to USA.
Schilling. No, Switzerland to Dr. Schilling. No, if you see the movie carefully, they go to Dr. Schilling. They take the name Dr. Schilling.
Stop saying we have not seen furniture.
Yes.
We all have seen furniture.
We welcome Dr. Sandeep Jain, consultant hematologist at Rajiv Gandhi Cancer Institute, and Dr. Vikas Dua, director of hematology oncology at Fortis Institute at Gurgaon. We welcome them. And with this,
right, so if there are no more questions, we close this session. Sir, thank you, Dr. Manas. Thank you very much. After battery.
we would like to honor the faculty. Right. Dr. Vipul.
I request Dr. Kamalji to.
इधर आ
Ma'am, please stay back. Dr. Manu.
Dr. Mukesh, please. Dr. Puneet.
Sir,
Thank you, sir. Thank you, Dr. Manu. Thank you, sir. We continue the next session.
So for the next session, a panel discussion on hemoglobinopathies and bone marrow disorders. I invite Dr. Amita Mahajan, ma'am, and Dr. Puneet Sahi to please join us on the stage.
5 मिनट आप बैठे 5 हाँ अच्छा leave a little early.
Whatever. So now I open this panel for question and answers. So all the delegates are can ask the questions, please. Right.
India, sir, yeah, iron overloaded hai, iron depleted hai. So we need to just set the balance. What is need of the hour is ironization of India. And a very prominent hematologist, very senior to us, he feels we are a third world country or LMIC. One of the major factors is iron deficiency. That is, for decades we were not iron deficient. Like we said, we would have many more Chandrayans already.
So if delegates are not asking the question, I'll ask some questions to the panelists. So what are the difference between intravascular and extravascular hemolysis? What is the clinical utility of such differentiation?
So intravascular hemolysis basically means that the RBCs are being broken within the blood, within the intravascular compartment itself. So in this situation, what will happen is that the haptoglobulin levels, which are going to combine with this hemoglobin, are going to be significantly reduced. In addition, what will be very distinct from extravascular hemolysis is that you will have hemosideruria and hemoglobinuria. So this is eventually ultimately going to result in polar colored urine. So such situations you can have clinically in something like G6PD deficiency, where there's an added insight. For example, there is a stressor or an infection, in which case the RBCs would be broken down within the blood compartment itself, or it can happen in certain other diseases like paroxysmal nocturnal hemoglobinuria, PCH. There could be certain other drugs which can lead in intravascular hemolysis. There could be certain infections like EBV which can result in intravascular hemolysis. Now, when you talk of extravascular hemolysis, this means that the RBCs either have an intrinsic defect in the membrane, they have an intrinsic defect in the hemoglobin, or there is a problem in the enzymes within the RBCs. So these RBCs, because of the abnormality, are sequestered within the spleen by the splenic macrophages. So since they're not being broken down within the blood, it will not result in hemoglobinuria or hemosideruria. Rather, these RBCs would be removed slowly within the spleen by the splenic macrophages. The clinical utility primarily lies in the fact that because if you differentiate between intravascular and extravascular hemolysis, you can narrow down on the differentials between the two.
Thank you, Dr. Puneet. It's really clinically, we should always try to differentiate whether it's an intravascular or extravascular, because our approach would be different, our set of investigations would be different, and then definitely the management would also be different. So the second question is to Dr. Amita, madam. What are the indications of regular transfusion in a child diagnosed with transfusion-dependent thalassemia or non-transfusion dependent thalassemia, and what is the target HB? Here I would like to add one more question. What all comprises of this transfusion-dependent thal? When we say transfusion-dependent thal, is it just the thalassemia, or it is an heterozygous state of HBE with thal, or alpha thal along with beta thal? So many times our residents ask this question. When we say TDT, is it only thal, or it could be the heterozygous state?
So that's why we have steered away from the words major, intermedia, because it really depends on the clinical behavior of the individual patient and what our target goals are. So usually when we refer to the transfusion-dependent thalassemic, it's patients who have required regular transfusions from early infancy, and some may not get transfused. So they had required but they never got transfused. That does not make them NTDT. So some infant who requires regular transfusion to maintain growth and development from early infancy is generally what we label as transfusion-dependent thalassemia. In our country, by and large, they will be homozygous beta thalassemic, but sometimes they could be compound heterozygotes. Non-transfusion dependent thalassemia is a term used when the need for the first transfusion was beyond the age of 2 years, and the threshold for the first transfusion we consider a hemoglobin of less than 7 on 2 occasions, at least 2 weeks apart, because an NTDT may transiently, they may be running at 8, 8.5, they have a viral illness, it goes down, but we should not jump because we have to know what is going to be our long-term plan. So we repeat again, and then we will take a decision whether we put this child on a regular transfusion program. For TDT, we would like to maintain a pre-transfusion threshold of 9.5 to 10.5 for optimal growth, development, and suppression of extramedullary hematopoiesis. The need for transfusion or starting occasional transfusion, many NTDTs will require. But when do we decide that we should now put this child on a regular transfusion program? For that, hemoglobin alone is not the criteria, but if a hemoglobin is consistently below 7, we should seriously think on putting them. But if there is excessive extramedullary hematopoiesis, failure of growth and development, poor quality of life, there is hepatosplenomegaly and facial dysmorphism, then on the balance, we have to take a decision to put this child on regular transfusion therapy, but almost always after a trial of HbF inducers like hydroxyurea, because some of these patients, if they have not received, we can maybe take a call after a trial of 3 to 6 months of hydroxyurea. TDT is easy. NTDT, every patient requires individualized management, and sometimes the social and logical constraints also play a factor on what we are. Does this child have access to optimal transfusion and chelation that we want to give him? In that case, we may have a we may not want the child to be at 7.5. We may choose a different thing. So individualize the treatment for every child based on the clinical status, the logistic issues, and in discussion with the family, because it is they who have to comply with the long-term plan.
Thank you, ma'am. Very well elaborated points. So, Dr. Puneet, why is a bone marrow biopsy essential to diagnose the case of aplastic anemia?
What happens is in aplastic anemia, the primary pathology is that the bone marrow has stopped making the blood cells. So there is a hypocellular marrow. Now, normally for most situations, we are doing a bone marrow aspirate. And the residents will be well aware that a pathologist, even if they write a hypocellular marrow, there is always a confusion. They add a thing, poor sample, because this is a diluted marrow. This is a very common situation in an aplastic anemia bone marrow because they anyways are hypocellular. So if you do not carry out a bone marrow biopsy, there is always a risk that the hypocellularity which has been documented on a bone marrow aspirate is actually because of the aplastic anemia, or it is because of the poor sampling technique. Secondly, in aplastic anemia, there can be patchy involvement of the marrow. So there could be areas where there will be hypercellularity, there will be areas that will be acellular. So in a biopsy, you have a more holistic evaluation of the bone marrow. So you're able to say conclusively whether the cellularity of the bone marrow is less than 25%, because that is one of the diagnostic criteria which has been given to diagnose aplastic anemia. Now, third thing is also evaluation of the other cells in the bone marrow which are present. So it may be aplastic, but there might be an area of the bone marrow which is hiding some leukemic cells. So actually, it might be an ALL which is presenting as an aplastic anemia, or there might be a clone of MDS. So it might be a myelodysplastic syndrome which might be presenting as aplastic anemia, in which situation the therapy might differ. That is why, in a case of aplastic anemia, it is imperative that you do a bone marrow biopsy. And here I also add, many residents, come to us and tell us that, oh ma'am, iska to platelet count is 10,000. How do we do a bone marrow? So thrombocytopenia per se is not an absolute contraindication for conducting a bone marrow biopsy. You can just do a bone marrow biopsy and apply prolonged pressure at that site after that. Also, it is recommended that you take at least 2 centimeters of biopsy. And what you have to be careful about is you don't end up picking the cartilage, because a lot of times residents who are new to the technique, they interpret the cartilage as the bone marrow biopsy. Someone who is attuned to taking a bone marrow biopsy should be taking. The third thing is you shouldn't be taking a subcortical biopsy. So bone marrow biopsy is to be done perpendicular at the PSIS. If you do it tangentially, there is a risk that you will take the subcortical area of the bone marrow. Now this subcortical area per se in many adults, in many children, is hypocellular. So you may falsely label it as aplastic anemia. So perpendicular biopsy, 2 centimeters length at least from the PSIS, and a biopsy definitely to make a diagnosis of aplastic.
So a biopsy is essential. We see cell morphology on aspirate, and the cellularity percentage is defined on only biopsy. So biopsy is essential. Bilateral is essential. So the next question is to Dr. Amita Mahajan. How long after blood transfusion can a sample for HPLC be sent to diagnose thalassemia? Can parental HPLC be used as an alternative?
So this is a very common situation in our setting where the child presents with severe anemia. The treating pediatrician may not have access to HPLC or may not have thought of it, and the child receives a emergency transfusion and is then referred to you or to a hematologist. So that answer is actually for a thalassemia, there will never be another opportunity to do a proper HPLC, because the red cell lifespan is so long that the child will certainly require the next transfusion before the previous transfused red cells go. 3 months would be ideal, but I cannot think of any setting in transfusion dependent patients where the next transfusion will not happen for 3 months. So if there is a window like that, that may still give you a nearly reliable test, but not an entirely reliable test. But as a surrogate marker, based on the clinical picture, the timing of transfusion, does the child have or hepatosplenomegaly, what was the peripheral smear, what was the CBC, what was the retic count, and if both parents are there, we can make a tentative diagnosis of thalassemia. Luckily, we have, but a definitive diagnosis in this setting is made by mutational analysis, and there is no urgency for that. You can give a working diagnosis of thalassemia, and there is now much more access to it. But if it's not immediately feasible, it can still be done at a later age so that we can definitely both confirm the diagnosis, and it will also give us much more information about the genotype and maybe some, prognostication of the overall picture of the child. So in our setting, very often we use that as a surrogate thing. We have no other choice. But just remember that you can offer mutational analysis at any point whenever it is feasible for the family, even to a, it may be possible at very low cost.
Right. Very well summarized, ma'am. So just adding on to it, when do we do mutational analysis in thalassemia children?
So ideally, everybody at diagnosis, because it can help us with some genotype, phenotype correlation. And also for antenatal, for the next prenatal diagnosis, they already have it. But if it is not feasible, it is not something that we would say that is essential for the management. It may help us. It has become easier. It has become cheaper. So we quite often do it. But it is not something that we would necessarily require to manage anyway.
Absolutely, ma'am. So, Dr. Puneet, why is it essential to differentiate between acquired and inherited aplastic anemia?
Right. So all of you should know there's something called acquired aplastic anemia, which occurs in nearly 70% of the kids, and 30% of the cases have inherited bone marrow failure syndromes, the commonest of them being Fanconi's anemia. In acquired aplastic anemia, almost 70% are idiopathic, and the remaining 30% you are able to identify the secondary causes. So when we talk of these acquired aplastic anemias, amongst the 30% in which you have an identifiable cause, you may be actually able to treat the child by treating that underlying cause. For example, if it is a child of SLE, so it is recommended that you do an ANA in all causes of acquired aplastic anemia. So if it is an SLE, then you treat the underlying SLE. Sometimes the aplastic anemia may be an idiosyncratic reaction to a drug. For example, sulfonamide, or there are certain anti-epileptic drugs which may cause an acquired aplastic anemia. So in this situation, the treatment would primarily be withdrawal of these offending drugs. So one aspect is this. The second is when you have idiopathic aplastic anemia and inherited bone marrow failure syndrome, specifically talking of Fanconi's anemia. What are the two definitive treatments we talk of? Either immunosuppressive therapy with ATG and cyclosporine, and the alternate is a matched sibling donor hematopoietic stem cell transplant. Now, if you give, in cases of acquired aplastic anemia which are idiopathic, either of these therapies have shown similar short-term responses. So both of them can be given. Bone marrow transplant, although it is the preferred if matched sibling donor is present, but IST is also shown to have good responses. Now, if in a case of aplastic anemia, you fail to pick up a Fanconi's anemia, and you give the same immunosuppressive therapy to that Fanconi's child, not only will he not respond to that therapy, he may have significant side effects and toxicity to that therapy. So it is essential that you rule out this inherited bone marrow failure syndrome, Fanconi's anemia, especially by a chromosomal breakage analysis. The second is when you talk of IBMFS, in them the treatment of choice is a bone marrow transplant. Now the conditioning regimens which are used for the bone marrow transplant in IBMFS are different from that used in idiopathic, aplastic, acquired aplastic anemia. So the conditioning regimen is much less toxic in cases of Fanconi's anemia. The third is when you have inherited bone marrow failure syndrome, you also have to follow them up for long-term follow-up has to be done for the development of secondary malignancies and associated organ dysfunction, which might be because of the disease per se. So this is how the management of inherited bone marrow failure syndrome differentiates from acquired aplastic anemias, and that is why it is imperative that we differentiate them when we diagnose a case of aplastic anemia.
So, right, Dr. Puneet, you were mentioning about chromosomal breakage analysis.
Yes, sir.
How long after blood transfusion can we do this test? And are there any alternatives to it?
Yes, sir. So this is also often a question because when we get these aplastic anemias, a lot of times when they're admitted with us, like in thalassemia, there's hardly a window we get where they are without blood transfusions. We kind of need to transfuse them frequently. But it is said that at least a 2-week gap should be there before you send the chromosomal breakage analysis, because that is a blood sample that you have to send. So to avoid the effect of the transfused blood, you have to wait for at least 2 weeks. Sometimes it is not possible to wait for 2 weeks because the child would be transfused in between. So in these situations, alternately, skin fibroblasts by using a skin biopsy can be sent for a chromosomal breakage analysis. The problem with this is that it is not universally available. And the second option we can have is doing a mutation analysis or a whole exome, because almost 3 mutations, FANCA A, FANCA C, and G, comprise almost 90% cases of cancerogenemia. So if you're able to identify them on a mutation analysis, or if you're able to run a skin biopsy and do it on a skin fibroblast, that might be an alternate.
Right. So,
Someone wants to say something, yes.
Madam wants to add a comment.
So I think that's very nicely put that you said that. So what we have done is now, for all children who are presenting with aplastic anemia, particularly if they're younger than 10 years of age, we are sending the panel of NGS for mutations. And in many patients where we didn't even suspect, they have no phenotypic features, they have no family history, we are finding many patients have mutations for the inherited bone marrow failure syndrome. The chromosomal fragility test, which, as you said, we wait for 2 weeks. The reason we wait for 2 weeks is because of the lymphocytes that might be there in the transfused blood. But that is again a screening test. You may miss Fanconi anemia, and the fibroblast test is not available. And as I said, if you're going to go for something as expensive as a bone marrow transplant or the immunosuppressive therapy, then I think it is worthwhile to do these molecular tests in order to identify whether these patients are going to respond, because not only does it have implications for this child, but it also has implications for other children in the family.
Well said.
And just to highlight again that 1/3 of patients with inherited bone marrow failure syndromes will not have any phenotypic features that you suspect that, he doesn't look like a Fanconi. That definitely does not exclude a Fanconi or even other something like this keratosis congenita.
So, are there any questions from the audience, delegates? Yes, ma'am.
Example also, we should be taking pre-transfuse, right?
No,
it's not required.
Any time sample
It is recommended at least 72 hours post, but it doesn't really matter because if the gene is there, the form says that at least 72, but sometimes it's difficult. The patient came in, he needs a transfusion, you ask them to come back after a few days, you'll miss the opportunity. Okay. So we might as well just,
So transfusion doesn't really change our decision of getting a whole exome sequence or clinical exome or a panel, targeted panel. Right. So any other questions? Yeah, Dr. Alka.
Like the diagnosis for any child who presents with aplastic victim.
Which viral panel are you talking about, Dr. Alka?
This is my question. DC and HIV. Unless it is very, you feel that this may be transient and then you consider CMV and EBV.
Yes.
But usually, by the time if they have already had it, so if it's very recent, you may choose to send that or parvovirus. But parvovirus is usually red cell aplasia, but can cause pancytopenia. So, but the kind of patient who comes with 2-3 transfusions, has had it for 3 to 4 months, in that case, the other viruses don't really matter. The hepatitis B, C, and HIV will alter how you treat the patient because you'll need to treat them. Okay. So even if it is CMV induced, but it is now permanent aplasia, your management will remain.
So that's my question is is there any implication on the management once we get these viral serology reports?
Or if you are unsure, the numbers are improving. Cellularity is less than 25%, but the count is actually better than before. In that case, rather than rush into any management, we might choose to maybe repeat a marrow after 1 month. So those decisions may vary, but if you are obviously the commonest known etiology for aplastic anemia in India is hepatitis C. So if it is there, you need to treat that, even though you may need to, you will do the management for aplastic.
So for the first time, we have to just send HIV, HBsAg, and HCV only, essential ones.
Right. Just adding on to what ma'am has said, it is said that almost 80% of the viral associated pancytopenias are transient. The remaining 20% may ultimately lead to aplastic anemias. Now, aplastic anemias, they say that the median age, if you don't treat severe aplastic anemias, some studies say that they may have spontaneous resolution with the median age varying from 4 days to almost an year. But almost 80% will self-resolve by 2 months. So if an aplastic picture and pancytopenia is persisting beyond 2 months, then it probably will require a treatment as is needed for an acquired aplastic anemia. And as Sam said, viral hepatitis, the commonest which is found actually in worldwide studies, they say that non-B, non-C, non-Z, seronegative viral hepatitis is actually one of the commonest causes which is present in 5 to 10% cases of aplastic anemia, and you get this history around 2 to 3 months prior to the development of aplastic anemia. They do not respond to, they usually do not spontaneously resolve and require definitive therapy and are poor responders. Thank you.
So the other thing to say is if you have a severe aplastic anemia, 70% of these patients will die within 1 year. So you have to treat them.
Chandra sir, so I have one question actually. What is the current status of Eltrombopag used in along with the immunosuppressive therapy? Are we using it currently?
There was this recent guideline published in IAP on aplastic anemia in Indian Pediatrics, February 2022. And although Eltrombopag has been used, it has a definite role in adults aplastic anemias. They say that when used in combination with IST, they have 80% response rate. In children, there are studies which are showing improvement, but it is not, the evidence is not so strong as to convert it into a guideline.
Similar for adults, it is the standard of care to combine. For pediatrics, the data is ambiguous and ambivalent. So some studies say, but with the current cost and the safety profile of that drug, I can say for sure that almost most of us are giving it, because if the data is ambivalent also, there is actually absolutely no harm in giving this drug, and the cost has come down dramatically with patient access programs and other things. So even if it may not lead to increased complete response, even if it helps us in reducing the number of platelet transfusions in the time to response period, I think that would still be a reasonable. So I think most of us would be adding it at the moment.
I think
we could combine data of such thing that adding Eltrombopag versus not adding. So what is your impression after adding this? You are getting some faster responses with the IST?
Definitely, our response is difficult to say because children generally have a good response, and that is why it maybe you may need a larger sample size to actually determine the additive impact of Eltrombopag compared to adults.
Yeah.
But definitely the need for transfusion requirement in the 12 weeks till we expect response to ATG, that seems to be definitely lower. I think Vikas would like to end.
I think it calls for a study in our own settings, and maybe.
But many centers may not be willing to not give L-Trombopac. That might hold us back, but we can definitely.
At least with the historical controls, we can check if nobody is giving. And maybe places like Maulana Azad and Kalavati, they might not be able to give consistently. So one can have the advantage. No, even Kalavati, before I left that place, we were using L-Trombopac in the plastic anemia. But then, as I said, consistently we can't. So one can make this thing. Yeah. And another thing is that there are still reports now coming up that even in patients of the hereditary or the anemias, the pancytopenias, like
factor. This is, I think, like an optional, what I already described. But if the patient comes to us in a bleeding state, where the patient has been compliant with the factor VIII administration and now has developed bleeding in spite of all the factor replacement, that is the time we must test for it. Another must is like when we have the patient planned for elective surgery. At that time, the patient is going to be like at risk of bleeding, and if it is a major surgery or minor surgery, we should look for inhibitors prior to starting the surgery. That is a must. So these two are must. Another must is like after surgery, even though the patient responded well to the factor that we gave during the treatment, now the patient has had a pulse, like lot of factor VIII was given during the surgery. We give it like twice a day, factor VIII, factor IX is given like once a day. Their half-lives are different. So in such situations, after the completion, we should look for inhibitors because exposure to lots of doses of factors, like any exposure to external protein would lead to, these are glycoprotein molecules, so they would increase the risk of inhibitor formation. These are the
practically for pediatricians who are sitting over here, the most important thing what we need to understand is that if the response to the factor is not appropriate, what you are expecting, the rise is not there. If the patient is still bleeding, check for the inhibitors. And second, if a hemophilic is being planned for the surgery, and let's say you have given a dose of factor which was required, and somehow the surgery has been done and the patient starts bleeding, you should have checked the inhibitors before, because if that is the case, the requirement might have been higher than what you have given.
So just to re-emphasize, the commonest time of development of an inhibitor, one is of course the surgery and other things, but the other is in PUPs, that is previously unexposed patients. The commonest is in the first 20 exposures. So you need a very high index of suspicion. And at that time, you need to screen. And this is, I think, the area where it gets missed. So yes, you're giving factor replacement, but in a severe hemophilia A, there is a 30 to 40% chance of developing an inhibitor. And that the highest risk period is in the first 20 exposure days, which will actually be in the first 6 months or so of the child. So please have a high index of suspicion. If you have, if cost is a problem, then maybe at least ask questions, find out about the response, and do the screening at that time, because if you do the screening and diagnose it appropriately, you may be able to prevent major problems in the future.
Yes, ma'am. And like another two situations would be when you are switching the preparations to extended half-life, or you're changing gears, or if there is a family history of factor inhibitor formation that increases the risk. In that case, we should be looking for it.
Right. Dr. Vikas, moving from slightly away from this topic, how would you diagnose acute ITP, and when would you like to do bone marrow examination in a case of ITP?
I think all of us know the fact that a patient who has been coming to you with bleeding, otherwise clinically well, no hepatosplenomegaly, you order a CBC, and the CBC shows a normal hemoglobin, normal white cell count, normal differentials, just the low platelets, you can say that this is most likely ITP and nothing else. So it's a diagnosis or exclusion. So you need to have a good history or a physical examination. Good hematopathologist should see the slides, and then you can say that whether it is ITP or not. And bone marrow test is not required in a typical case of ITP, and a typical case is a well child with no organomegaly, a normal hemoglobin, a normal white cell count, just the low platelets, and has come running to a clinic, otherwise looking well.
Right. Dr. Kamalji, what are the indications of treating an acute ITP?
So is it for me?
Yeah.
Okay. All right. So indications for treating acute ITP, actually it's clinically treated. So if the patient has no mucosal bleed, it's just PTK, there is no indication of treatment of ITP. Only if the patient has wet purpura or there is a suspicion of mucosal bleed like GI bleed, I mean, you can have menorrhagia, epistaxis, all those situations, then we warrant ITP treatment. And serious conditions obviously don't need an answer. ICH, intraperitoneal bleed, then we don't question. So the call is to be taken when the patient has low platelet and skin bleeds, but nothing else.
I think we all need to decide whether we are treating our anxiety, parents' anxiety, or actually the patient.
Right. So, Dr. Tolika, what are the drugs which we use in the management of acute ITP? And what is the first line, second line in managing acute ITP?
So for acute ITP, things have not really changed. You have steroids and you have IVIG. And that is pretty much what is recommended in the American guidelines, the recent ASH guidelines, the European guidelines, and I think that is what we are practicing as well here. If we are talking about chronic ITP, then definitely the guidelines have changed and TPA receptor agonists have really come to the forefront in that group. But for acute ITP, IVIG, steroids are still the backbone.
So, would you like to use low dose for longer duration or high dose for a shorter duration?
So in pediatrics and adults, that's where the main difference is. In adults, we tend to use steroids for a much longer duration, and in adults, I would include the adolescents because the responses are fairly similar to adults. For pediatric patients, we always recommend using a higher dose but very short duration. So traditionally for acute ITP, I don't give steroids for more than 2 weeks, and most of the time you really don't need them for more than 2 weeks in a acute ITP trial.
Right. So we'll talk something about oncology also. Gauri Kapoor, ma'am, what are the common childhood cancers and how common is leukemia in children?
Let's ask from the audience.
Right.
What is the commonest cancer?
That is also.
Come on, quickly. Boliye.
AML? ALL, okay.
Common cancer. 3 most common cancers: leukemia, CNS tumors, and lymphoma. तो ब्रेस्ट कैंसर किसने बोला? बच्चों में पूछ रहे हैं. ये पीडियाट्रिक का सेशन है. So they are the 3 most common. And then what was the second question? How common? So, anybody, how many cancers in India every year?
Very tough.
Come on. आप लोग ने अटेंड नहीं किया? हाँ. So estimate है, हमारे पास भी accurate data नहीं है. It's about 50-60,000 cancer cases. Out of that, internationally 25% are leukemias. But as per ICMR and the hospital-based registries, almost 35% are acute leukemias. So if you calculate that way, 9 to 10,000 new cases of acute leukemia are diagnosed each year, which is more than the total number of pediatricians in our country. So each pediatrician may not even see 1 case if they are in the just seeing 100 cases a year. Say.
Right. Right. Sorry, please, sir.
So the brain tumor are the second most common, or is it the lymphoma is the second most?
Sir, I think it's the relapse of leukemia
ICMR
which is most common rather than brain tumor. So relapse of acute leukemia would be, I think.
That's the 4th most common. So actually, sir, if you calculate all, there are some hospitals which don't have brain surgery, the neurosurgery department. So they will see few. But those hospitals which have the neurosurgery department, they see a lot of cases. So the distribution across hospitals depends on what kind of infrastructure. Also, the benign tumors often are not considered. The low-grade gliomas are not counted. So if you count together, the ICMR shows brain tumors to be.
Right. So thank you, ma'am.
So
Doctor,
what is the most common? You said so.
Relapse.
Relapse. So after that, any other 5th, Sandeep? Yani? Bone tumors. Bone tumors. Okay. So malignant bone tumors.
That will be pretty low. Right. So, Dr. Sandeep, what are the red flag signs that a pediatrician should know to detect childhood cancer early?
So, as ma'am told, childhood cancer is not a common disease, only 50,000 cases per year. Therefore, we need to have high index of suspicion in certain scenarios where we have to consider the possibility that child may have cancer. Like in leukemia, there are certain red flag signs, and we call them red flag signs. Like in a child who is having fever for more than 10 days, there is no clear-cut focus of infection. He's not responding to antibiotic. Then one should consider that possibility that child may have some marrow disorder. Then, say child has pallor, which is not responding to hematinics. It is recurring, like requiring blood transfusion. Say child has a hemoglobin of 10, it drops down to 6 in absence of any hemolysis or blood loss. Then one should consider a possibility of acute leukemia or marrow disorder in such scenarios. Then if a child presents with bony pains, we often attribute it to calcium, vitamin D, but it is not so common. We must consider that the child may have a marrow disorder in such situations, and bone pains are not common in children. Then pancytopenia. Sometimes we, as a pediatrician, we might think that the child with leukemia should have hepatosplenomegaly, lymphadenopathy, and high counts, but it is not always so. A child with acute leukemia may also have pancytopenia. So in pancytopenia also you should consider a possibility of acute leukemia. Then coming to lymphoma, painless enlargement of lymph node, which is the most common presentation of lymphoma, and most of the time it is treated as tuberculosis empirically. So that is one thing I would like to give a message. So in a patient with a enlarged lymph node, don't start AKT without confirming the diagnosis. That may be a manifestation of Hodgkin lymphoma. Child may be very well looking and they may have lymph node for months. It is not that the lymphoma will arise like just in 1 month or so. Patients with Hodgkin lymphoma may have lymphadenopathy for a very long time. In fact, in one of our study which we conducted in the Hodgkin lymphoma group, 40% of the patient actually had received AKT before being diagnosed with Hodgkin lymphoma. So that is the other thing. Then in any child who presents with acute intestinal obstruction, chase the histopath report, because that may be a manifestation of Burkitt lymphoma or a high-grade non-Hodgkin lymphoma. And any child presenting with the intussusception, you must consider a possibility that this child may have underlying lymphoma. So other than that, any child with some mass in the abdomen, especially after first year of age, you should consider possibility of malignancy, because in a child more than 1 year, any abdominal mass, it is more likely to be malignant than the benign tumor. Wilms tumor, neuroblastoma, germ cell tumor, teratomas, these are common in children with abdominal mass. Then any extremity mass or any testicular mass or any mass which is like not impinging, which is not like causing any signs of infection. So you should consider the possibility of cancer in that. Then coming to brain tumor, which is like one of the quite common cancer, second most common cancer in children. Any signs of raised ICT with squint or eye deviation or with poor school performance or ataxia, headache, vomiting, especially early morning vomiting, you should consider possibility of child having a brain tumor. So these are the common signs and symptoms which often children have with malignancy.
Well, it's a quite the range described by Dr. Sandeep is really great. So, Dr. Pelly, what are the causes of childhood leukemia and how is it different from cancer in adults?
So first of all, as we just mentioned, that the type of cancer, it is actually different. Somebody mentioned breast cancer. It is absolute no, because we get to see more of leukemias, lymphomas, brain tumors, and embryonal tumors in the pediatric age group as compared to adult. And in adult, whereas we see more of breast, colon cancer, cervical cancers, all these. Coming to if you look at the causes, one can see a high mutagenic load in the adult cancer as compared to childhood cancers, and a long latency which is seen in adult cancer. A person starts smoking, the time when you would get a lung cancer is actually long. Whereas pediatric cancers, many embryonal cancers, the origin is seen in the in utero, where the latency is very low and mutagenic burden is less compared to adult cancer. Looking at the environmental risk factors for cancer, they contribute only less than 10% for pediatric, whereas in adults, they are far more. After the type of cancer, coming to the cancer treatment, yes, they're definitely better as far as the childhood cancers are concerned compared to adults. They fare much better than adults, less of toxicity and good outcome. Regarding when we talk of the differences coming when the children are surviving more, one important aspect which has to be taken care is the long-term survival. Since they are thriving well of the cancer, we have to look at the late effects, which is many times, obviously, a adult having cancer is not going to live maybe 5-10 years down the lane, but a pediatric childhood cancer survivor has a long way to go. So most important is to look for the long-term effects of cancer therapy. And regarding treatment, there are, again, since mutational burden are very high in adult cancer, the targeted therapies, they are far more commonly used in adult cancer compared to pediatric cancer. Anything else?
So, no, it's fine. Any questions from the audience till now? Yeah, please.
And one more thing, that genetic syndromes, both chromosomal and non-chromosomal, they are the causes of various childhood cancer. And if you look at very common Down syndrome, very common example where they are prone to various malignancies. Coming to certain embryonic tumors like hepatoblastoma, neuroblastoma, Wilms tumor, they're associated with various non-chromosomal anomalies. Low birth weight, more of hepatoblastoma, high birth weight, brain tumors, Wilms tumor, and Noonan syndrome, Bloom syndrome, and certain PIDs, primary immunodeficiency in kids, they're prone to malignancies. Sorry, just question.
Please, you were asking something. So we have to see in the context of the illness. So suppose growing pains, it's a 12-year-old child who has like occasional pain. But if this pain is persisting for some time, then you have to see the signs of inflammation are there or not. If there are no signs of inflammation, then you first rule out any infection or something like that. If there's no signs of infection and it's just vague pain, then I would suggest that if it is persisting beyond 2 weeks, 3 weeks, then do a CBC. This is like CBC and peripheral smear. This is a basic investigation that you must do because this will give us some idea about the underlying pathology. If child has some serious illness which is causing this bone pain, CBC and good peripheral smear examination should give you some idea. So any pain which is like bony pain which is persisting beyond 10-14 days and you don't have clear-cut reason for this, it should be investigated further.
Can I add? So when to suspect leukemia in a child with bone pain? Is that your question also? So what are the 5 P's of leukemia? Pallor, fatigue, pyrexia, pain, and peripheral blood showing blast. So no one sign or symptom will help you diagnose. You're a good clinician, you're a good pediatrician. Take a good history examination and find out if bone pain is the only symptom or any other associated findings are there. So you will not miss. The way we teach in our workshops is have a high index of suspicion, but do a good history examination and a good clinician will not miss the diagnosis. The whole story is don't miss the diagnosis.
Clinical methods of such as if you make a common diagnosis, you are commonly correct. If you make an uncommon diagnosis, you are uncommonly correct.
But here we are here to propagate. Do not miss the diagnosis.
Right. Any more questions from the audience? Yeah, please. Sir.
I have a very basic question. If I get a bleeding hemophiliac in my clinic, I don't have access to factors. What are the best practices that I can do to help the patient?
Hello.
So depends upon the type of bleeding you have. So if it is nasal bleed, oral bleed, or it is a joint bleed, intraperitoneal bleed, or intracranial bleed. So approach differs depending upon the scenario. So if you're talking about a simple bleed like nasal bleed or oral bleed, all you need is pressure. Is a known case of hemophilia, even that is also important, right? And you don't know whether it is like other hemophilia patient or it's like a ITP patient, etc. So we assume we are talking about a patient who is a known hemophiliac, who is non-cooperative with his, non-compliant with his treatment, and now has come to us with bleeding. So mucosal bleed, you can do like apply pressure locally, apply ice packs. Similarly for gums, then you can give Trenexa tablet orally, or you can give apply Trenexa paste locally made from the tablet. So these are the few things that you can do. This is for the mucosal bleed. For the lady who has menorrhagia, you can try, in addition to Trenexa, you can try oral contraceptive. So that is one way. Other is about the joint bleeds. If you have access to, like besides Trenexa, it will not cause harm to the patient. Besides this, you can give FFP if it's a case of hemophilia A or B. Hemophilia B can be given same FFP, but cryoprecipitate cannot be given for hemophilia B. So these are the two things, like two drugs, and plus the supportive things that you can give. If intracranial bleed, I guess you better have factor 8 with you. And for intraperitoneal bleed, neck bleed, these are considered serious life-threatening bleeds, and they need factor 8. So you should, by the time you start FFP, etc., you should be transporting the patient as well. Most important thing I want to emphasize here is, if a patient who is a known hemophiliac comes to you with an altered sensorium, you don't want to confirm the patient, whether the patient has intracranial bleed or not, and waste precious time, has abdominal tenderness or some neck swelling. I would rather give factor 8 and then image rather than lose the time. That is simple.
So, I mean, I would like to know what are cases where factor 8 cannot be made available.
So government now, in most government hospitals, state hospitals, there is provision of free factor for hemophilia patients for emergencies. Yes, we don't have enough factor for prophylaxis, but for emergencies, it's usually available. So please check with your hospital, make sure that they have it available, and make sure that the emergency or wherever you have it, it is there. Because nowadays you may get into legal problems, and FFP, cryo is not always easily available. Even at my center, I have to tell the blood bank and they have to prepare it, and sometimes it takes a few days to get cryoprecipitate at my hospital. FFP you can get, but then there are other problems with FFP. You can get allergic reactions, there's infection risk. So factor, as Dr. Jagdish has said, it is now freely available through the government. So if your hospital is not getting it, government also will not support you. They'll say, we made it available, it is your issue.
And if you have blood bank in your hospital, FFP is not routinely consumed, like platelets are consumed, PRBC is consumed. So among the blood products that are generated from the whole blood, FFP is the least consumed, only in ICU setting, etc. So that FFP, Reliance is providing factor 8, plasma-derived factor 8 in exchange of FFP to the government hospital. So you can get that also. You don't want to give plasma-derived, but at least you have plasma-derived factor 8. Good question. So, you want to ask about any recent history of any fever or infection, any prior bleeding episodes, any recent vaccination, then any other bleeding site, then family history, any history of previous blood transfusions, any history of recurrent infections, and how the child looks. If there is any drugs, any anticonvulsant medications or any other chronic medications the patient is on, other autoimmune disorders or skin rash, tendency to skin rash, failure to thrive, and obviously the physical examination will give you more than enough, right? Anything you want?
I want to know a patient maybe first time presenting to us with bleeding manifestation, with hematoma on a cheek, then on multiple site ecthymotic lesion. And while doing platelet count was normal, otherwise hemoglobin percentage was very low, anemic, but there was no fever in the patient. And while doing one factor assessment, his factor 8 has come as a 71%. And on that lab parameters, on the reference level was from 70 to 150. And factor 9 also, he did is 38%. So in this situation, he's like borderline in factor 8 essay. So what to do, to be considered as factor 8 deficient also?
That's a very common scenario. So let me ask the house before we answer this. So, the question what she's asking. She's saying that you have a patient in your clinic who has got a hematoma and you got a CBC and a PT-INR and an APD done. And in that, your platelets are normal, your PT-INR is normal, your APDT is prolonged, and you ordered a factor 8 and factor 9. Your factor 8 is 71% and your factor 9 is 38. That's what you're saying. So how will you approach and what will you do? So let me ask the house before we answer this. Very common problem, very common scenario. So is 71 normal? So anything between 50 to 150% is normal. So 71 is normal. The other thing, 38% of factor 9. So we need to understand what is hemophilia B. Hemophilia B is severe is less than 1%, moderate is 1 to 5, and 5 to 30% or 5 to 25% is mild. Then what is this 38? Probably there is an issue with the transportation. The sample is not been run at a correct time. You have to do the test very fast. You have to run the sample in 2 to 4 hours because these are labile factors and the factor levels will go down. So probably this patient neither has got hemophilia A nor hemophilia B.
Okay. Another issue is that in newborns, you have to look at age-related PT, APTT, right? So that is another thing because most of the labs will just have the adult, and we often get some of the private neonatologists come to us that, oh, I have this prolonged PT, and when we do it as the age appropriate, actually everything is fine, and they're just unnecessarily keeping the baby in the ICU. So for newborns, you must make sure that you're getting age appropriate labs, and two, as very nicely highlighted by Vikas, a minor reduction in several factors means that you had a delay. So we often used to get like these patients who were referred to us as both hemophilia A and hemophilia B, and obviously that is not going to happen. And if they had tested for other factors, that also would be like a pan factor deficiency because you keep the samples. So we would get like samples sent from Manipur to Bombay, and then you come back with this kind of a silly report. So you need to check with the lab. Most likely, nothing is the problem.
So we have initially have to treat it with FFP only, madam. Because this factor reports, it took around 7 to 10 days to get the report. Because we have to send it to Delhi from.
No, so you must not send to Delhi. Yeah, exactly. Yeah.
Yes. No, he was like, that's not possible.
This actually question has raised several issues. First of which I wanted to discuss here. So collecting the sample for PT, APTT is like a proper procedure. Patient should be rested. As madam had highlighted, a crying child, a stressful situation will alter your clotting factors and will alter your report may come falsely normal also if a patient is stressed. So rested patient and free flowing blood. We are looking at APTT pathway. If the patient this sample is squeezed blood, the tissue factor, PT pathway will be activated, tissue factor is released, and that will alter your results. So, and the parameters will change. So the sample should be free flowing, properly rested, and the temperature to transport, the time is important. Within 2 hours, the sample should be, the PT sample that is collected, it should be centrifuged and it should be platelet poor plasma. That is, that, but not the whole sample. And 18 to 24 is the right temperature. At a higher temperature, the factor will break down. At a lower temperature, the clotting system will start activating. So they will all, even the fridge temperature is 18 to 24 is the right temperature. Platelet poor plasma, I mean, that is all, logistic is more important.
The right ratio of blood to anticoagulant. If it is a small baby, then you need to get a smaller tube made by your lab. So there's many things. So sometimes it is just easier to send the patient to a higher center to get the testing done. But otherwise, you're just going to be chasing a wrong report, and it's just going to cause more confusion and more trauma to the family.
So is there any diurnal variation, ma'am? Suppose if I send a sample blood draw doing in the morning hours or the evening, that's
if you're having that kind of an issue, it is laboratory error. You don't have diurnal variation. Maybe the people in the afternoon are doing.
I want to know, I'm asking, to send a sample in a temperature, not to get the high temperature affect the sample. Because our patient from the ward, they go, when they go to deposit the sample, so it takes around almost more than sometime in the 3 hours also. Because it's a huge patient crowd and they need to.
So you need to prioritize, because you need to tell the lab that this is an important sample, it is for a coagulation test. So then they can have a separate line for the coagulation test. Universally, wherever you go in the world, it is there, right? You can't have this sample run last after you've done all your other samples.
Another important thing is bleeding questionnaire, that is pre-bleeding questionnaire, that is important. Bleeding assessment tool that we use in the adults, because what is happening is a test may come back normal. APTT may be normal and patient may still be having von Willebrand disease if the factor deficiency is mild. So patient is bleeding during stressful situations, but is coming to us and we are having reports again normal and again. So proper collection of the sample and then storage, transportation, and then if we have high pretest probability as per PBQ questionnaire and the cutoff is less than 3, higher, we keep a lower threshold for diagnosing. In such cases, we can pursue higher, we can directly go for the factor assay even if the PT-APTT is normal. 18 to 24 is what the book says, but it's hard to do it in real life. So it has
always better to send the patient to the lab, because you cannot ensure the traffic today is impossible to predict. So we had a patient. This was a male child, adolescent male with the skin bleeds only, recent onset. Last 1 month he is having recurrent skin bleeds, and when we order this coagulation profile, his PT is prolonged with INR of around 3.8, and APTT is just mildly prolonged. Initially we thought that this child might be having some viral infection associated liver dysfunction or something. So he was given that vitamin K. With that APTT got normalized, but PT remains prolonged. And even on 2 or 3 further occasions, the PT is prolonged. So now at this point of time, what we have to think in this particular child and how we should proceed for diagnosing this child.
I think if your PT INR is prolonged and APT is also prolonged, and you have given vitamin K, and now your PT INR is prolonged, first and the foremost thing is to do a mixing study.
Okay.
Do a mixing study and rule out lupus. Adolescent patient.
Male. This was a male.
That's what I'm saying.
Yeah.
Not each and every adolescent girl would be having SLE. You need to do a mixing study and rule out lupus. And if that is also not the case, then you need to think of the causes of prolonged PT INR which may be liver disease, which may be factor 7 deficiency. Sometimes you can have an acquired factor 7 deficiency also.
So that's my question is, how common is this factor 7?
Common,
Because in this child, LFT liver function tests are all normal. These factor 8, factor 9 assays has also been done. So those were also within the normal range. So how common is this factor 7 deficiency?
So first of all, in lupus, it's usually a prolonged APTT.
Yes.
And prolonged PT-INR, one, make sure that there's no drugs. Second, you make sure that there's no liver dysfunction, which you've already seen. Factor 7 deficiency does occur, and in India, we have seen it. And factor 7 deficiency is a little bit unusual in the sense that the actual factor level does not always correlate with the bleeding.
Yes.
Unlike in hemophilia, where there's a wonderful correlation with your factor level and the severity of bleeding. In factor 7 deficiency, we don't see that. We have patients who have very severe factor 7 deficiency and have rarely had bleeding, and we have patients who have milder factor 7 deficiency who come to us very frequently. So I think it's important to see if this is either an inherited factor 7 deficiency, or you may sometimes see it as an acquired factor 7 deficiency, just like we see acquired hemophilia. So investigate and let us know.
My question is whether we have to go for factor 7 level.
We should, yes.
Okay. Because this is not available in house.
Send the patient.
Do a mixing.
Yes.
Do a mixing and document that there is a factor deficiency.
Okay.
Because on mixing, if it is getting corrected, then probably there is a factor deficiency.
Okay. Thank you.
Good morning, sir. Myself, Dr. Aditya, PG1, CNBC. We actually got a case who was a 5-month-old male child. He was referred from some other hospital with the complaints of prolonged bleeding from injection site. So we investigated. We did all the PT and APDT. For that child, PT and APDT both were prolonged. We gave FFP also, and we also sent for mixing study as a sir said, and it came out to be normal. And then we did factor assay. That child came out to be factor 5 deficiency. So in this ma'am's case, as she said, APDT was prolonged. We could also think of other factor deficiency like 12, 11, 9, 10, right? Because in her case, APDT was prolonged. So it could be a case of like 12, 11, 9, 10. That factor deficiency could be the possibility in ma'am's case, right? So I'm asking.
I don't know. She said it was PT prolonged. So I don't know. You can discuss that.
No, this ma'am said APDT was prolonged for the child.
It won't correct if it's a factor deficiency. It won't correct if it's a factor deficiency. So if you have factor 5, 10, or any of these deficiencies, that won't correct with vitamin K. So that's why we were assuming it was a PT.
She said for APDT, right? That ma'am.
Oh,
she said about that the child came with some bleeding and all, and APDT was prolonged. She did all the assays for which 38%.
So what we said is that the patient was probably not having factor 8 and factor.
That's what we said. So that means
if your APDT is prolonged and your PT-INR is prolonged, then definitely you have to see the common pathway.
Okay.
But also, if you're sending the test from Assam to Delhi, you're not going to get a correct report. Even your PT, APTT are going to be get affected. So don't send a long distance.
That is why pre-test probability is important. If it is just first episode of bleeding the child has come with, or a single site bleeding with normal birth history, probably you are dealing with not dealing with a hemophilia or something. So that is why the pre-test probability is also important. That is how far you will investigate, whether you go for factor 5 or wait for second bleeding to occur.
Yeah, so I think that's really important. So like epistaxis is such a common problem, but every child who has epistaxis does not need to have a full coagulation workup. So if you have a child who has epistaxis only from one side of the nostril, it stops, with minor pressure. There's no anemia, there's no bleeding from the skin or any other side, and the patient's not anemic, maybe you don't need to investigate. Versus you have a child who has, profuse bleeding, bilateral, often needs to go to the emergency for packing, or bleeding in the skin also. So then definitely that person needs a coagulation workup. So the pretest probability, the question, the history, the questionnaire, those things can give you a clue.
There were two siblings we had, ma'am. One 5-year-old girl, another 8-year-old boy, with no history of consanguinity, and they have presented with multiple skin bleeds since early childhood, and in the boy, they were gradually improving as per the father. Gun bleeds were also present. Platelet count was normal. We got a coagulogram in which APTT was normal, PT was slightly prolonged to the tune of 24 seconds as compared to the lab, which was giving us 17 seconds. The control was 17 seconds. And we gave a shot of, we did a peripheral smear, sent for a platelet aggregation study. And we also flow cytometry as well as aggregation, in which glandular thrombopenia was reported. We gave a shot of vitamin K, and the PT was still prolonged. On 2 consecutive days, we gave a vitamin K. PT was still prolonged. We got a factor 7 assay done from Lalpat lab. Came out to be factor 7 deficient to both the siblings. So now, and I was reading, I'm not, this is probably the first 2 cases of glandular thrombopenia that I am seeing, because the platelet function tests have just been started in our institute now at Nancy. So, but I was reading that recombinant factor 7 is also used in the treatment of glandular thrombopenia. So, is there a correlation between, I mean, is it an incidental reduction?
I think you need to investigate this and report this, because this is actually not correlated. Glanzmann's is not uncommon in our country. I remember giving a lecture in Hyderabad on bleeding, and I said the second commonest bleeding disorder was VWD, and I remember everybody stood up and argued with me, and they said, no, Glanzmann's is much more common. So in India, even though we don't have a lot of consanguinity, but we do have something called endogamy, and that can also increase the risk of recessive disorders. And we published our data on rare bleeding disorders, and factor 10, factor 7 are not so rare in India. So, and Glanzmann's also. So the reason why recombinant factor 7 is given for bleeding in Glanzmann's is not because there is a factor 7 deficiency, but because recombinant factor 7 works as a bypassing agent for many bleeding disorders. And in Glanzmann's, we usually recommend platelet transfusions, but unfortunately, some patients may develop allo antibodies to platelets, and some patients may not respond to platelet transfusion. So if there is a severe gastrointestinal bleed or intracranial bleed, then recombinant factor 7 may be life-saving in these Glanzmann's patients. But this, I think, is, we have actually a large cohort of Glanzmann patients, and none of them have factor 7 deficiency. So I think this is very interesting, and you should definitely investigate and report these patients.
Yeah. Right, ma'am. Thank you.
Before reporting, you need to recheck that.
Yes.
In a same family, you have a platelet function defect and a factor 7 deficiency. Looks a bit unusual.
Very, very unusual.
You have to repeat it from a different lab.
There are also molecular tests that you can do. But yeah, I mean, if you're confident with your report, then definitely
go ahead with the molecular. Yes, ma'am. Thank you.
Any more questions from the audience? If there are no more questions, we'll close this session. Thank you very much for all attending. I would like to call upon Chandra sir to facilitate our judges for this panel discussion. You want? सर कह रहे थे oncologized कर दिया, अब ये hematologized कर दिया है, इसको थोड़ा oncologized. We have lot of questions. We can. I thought the time was against us, but if time is with us, we will definitely. So, ma'am, first of all, we would like to know what are the indications of bone marrow transplant in cases of acute leukemia?
Mike, sir.
So I will ask the audience, is ALL an indication for bone marrow transplant? How many are saying yes? So why don't we do bone marrow transplant in ALL? Anybody? Because it is curable with chemotherapy alone. So where would you like to do a transplant in leukemia? Relapse ALL, at least an early relapse. Any other? High risk ALL. What kind of high risk ALL? MRD positive ALL. Okay, let me ask you, AML with 922, you want to do a transplant in all cases? Anybody? ALL with BCR ABL. Is it possible for ALL to have BCR ABL? Yes? Okay. What percentage of ALL have BCR ABL positivity? Is it common or rare? Yes, good, 5%. What is the size of the P? 120, 190, 210? What you have read? Okay, so the first thing is that MRD is very important. And MRD positive leukemia, especially after first and second month, we want those patients to go for bone marrow transplant. But the important thing is you want to intensify treatment and then only make the MRD negative and only then take for transplant, because it is not like you do transplant and they are cured. Right? For relapse ALL, also the cure rate with allogenic bone marrow. So we don't do autologous bone marrow transplant, only allogenic bone marrow transplant. Even with that, the cure rate is 10%, 40%, 80%. Anybody? Audience? 40% or 80%? What will you tell the patient who has relapsed, who has a sibling matched donor, and he is going to go for transplant? What will you tell? Because he will come, you are the pediatrician, he will come to you and he will ask you, so-and-so is saying, let's do a transplant. Will you recommend? What will you tell them is the cure rate? So if MRD is negative and there is a matched sibling donor, it will be up to 60% cure rate. What about AML? Will you do AML transplant in first remission? What about 821 translocation or inversion 16? Will you do transplant? Why will you not do? Because it is favorable risk AML, and what is the cure rate for these? Almost 70% with chemotherapy. So all those acute leukemias who have good cure rate, you don't want to do transplant. Why don't you want to do transplant? Does it add anything to the event or relapse? Does it reduce the relapse rate? Yes. It reduces relapse rate in 15 to 20%, but still why we don't want to do? Because there is a higher transplant related mortality. So there is a toxicity, there are more late effects like infertility also. So you don't want to do transplant because it is a more toxic treatment than chemo alone. So those ALL and AML patients which have a favorable risk disease, which can be cured with chemo alone, we don't want to do allogenic bone marrow transplant for them. Then other hematological disorders like relapsed Hodgkin's, relapsed non-Hodgkin's lymphomas, also we do transplant, but here we do often do autologous bone marrow transplant.
Please, sir.
Okay. I can only tell you pediatric data. Yeah. So we have seen children up 20-25 years, but not more. You are saying TKI, how long TKI? So in the world, I don't know.
My personal experience.
We have seen up to 20-30 years.
I've given imatinib in one patient for the last 18 years. and we have a cohort of patients who, first when I joined IRCH, I started them on imatinib when it first came through the GPAP program, and they're still with me, and they're adults, they're married, they're doing well. So up to 18 years, I can tell you that I followed them. First line imatinib. Yeah. Yes.
Even our patient, he's 35.
But at the same time, I have patients who I have transplanted also, pediatric. And these were patients who did not get a good response to imatinib, and they were like the first transplants that I did. First I remember is 2005. I did a transplant for CML. He's now back on imatinib because post-transplant, we followed him for many years. Initially, his MRD was negative, but then there. So TKIs are actually very good.
Where today, maybe a 55-year-old patient who is died, a PKI exposure for this fellow was going to live for another 70 years.
Yeah. So there are side effects.
18 years, when he is adultoid, you know, you build up the semen or ova and transplant. Is that a better approach or you continue giving PKI?
So that's a really good question. Yeah.
सर ये हमारा एक पेशेंट है यूएस में है एंड ही इज ऑन फॉलो अप विद ड्रुकर नाम है ना जिन्होंने ढूंढा था इमाटिनिब. So he is now this chap, he is 35, he is married, he wants to have a child. So he is on follow up with Drucker. And Drucker said even I don't know the correct answer. So first he said तुम बंद कर लो बच्चा हो जाएगा फिर चला लेना. So लेकिन he said दे दो.
So we've actually done a study on this, sir, Dr. Chandra. No, generations में नहीं देना होगा. Why will you give first generation, second generation?
TKI generation. TKI.
Okay. No, so
my
let me answer that.
First generation TKI. He is still on first generation. In fact, I have another kid. He took 10 years and then he stopped it for 5 years. He came back to us with frank CML chronic phase. He started in 3 months molecular remission again. And now he's again 25.
I think the guideline for adults is that if they are continuing molecular remission for 2 years, the stop trial, they will discontinue.
So the stop trial is with second generation TKI. But if you're using first generation, then it is for a longer period of about 7.
Yeah, but the last 2 years should be, so about 50%, regardless of the duration of remission and duration of treatment. When we discontinue, 50% will relapse, but they will all go back to their previous baseline remission state.
They will relapse.
And that's they will achieve second CR2.
I think there is some confusion in this aspect.
Because now the children also, it is because again, duration and the growth and other disturbances that we can consider, but we need to monitor very carefully and the family needs to understand. Accidental pregnancies or unplanned that have happened, either in male part, the male partner is taking imatinib, or if the lady herself is on imatinib, there is not a lot of data on adverse outcomes. It is still recommended not to do, but it has happened, unplanned pregnancy. So termination is not to be advised if that has happened, because the current evidence doesn't support that. It will be a very high incidence. Counseling can be done, but it's not an absolute indication for termination.
So we've actually done a thesis on this, and we found that in males who were taking imatinib, we did a study on sperm count. We did an initial sperm count and analysis at baseline prior to starting imatinib. And then we did a subsequent sperm count 6 months down the line, and we actually did not find any differences. So, and the current guidelines for males who are on imatinib is to interrupt. They can continue if they're planning a child. For females, we recommend, if possible, for them to stop the TKI. There are definitely problems with nilotinib that can cause hydrops fetalis. And in fact, if you read all the guidelines for all the TKIs, first generation, second generation, they're all not recommended in women who are pregnant. In those, you can give interferon alpha. But for males, they don't need to stop. The second question that you're asking about whether to do transplant or not to do transplant, there is really no consensus on that. There are a lot of people who are working on pediatric CML. So generally people feel if you're getting a good molecular response, if you're not having the side effects of growth and other things, you may continue with TKI. The reason being the transplant is actually not the best treatment for CML. Earlier, when we used to do transplants for CML, the majority of these patients would eventually relapse and need to be put back onto TKIs. So relapse is a wonderful therapy for many disorders. For some reason, the graft versus leukemia effect is not so evident in CML. And so you may want to reconsider that as the ultimate curative thing is not there. The benefit that we get from the TKIs and the newer TKIs that are coming in, one of the very exciting things is asciminib. And asciminib is effective even in patients who have T315I mutation. So I think it's the TKIs are still okay. And as I said, if you follow these patients, they can have a very long-term, good quality of life.
So this situation is similar to the ERT versus transplant, right? So in this case, we were having lecture. I think Dr. Pradeep, he had come from US, and he was talking like transplant-related mortality even in their setting is 10%. So here we are looking at whether we could be able to stop imatinib at later date or not when the sufficient trials in the pediatric population come in versus the 10% mortality. So that is where we kind of have on the back foot. 10% transplant-related mortality, even in the West, in experienced hands.
So another very interesting thing is that patients who respond well to first generation TKI, they don't necessarily need to go on to second generation. There are a subset of patients which now are being evaluated who develop rapid mutations, and they will develop mutations with different things. So we don't really understand this phenomena. More than 90% of our patients are still on the first generation TKI and doing well, but then there is this 10% of patients where whatever TKI you put them on, they tend to develop mutations. So perhaps there is something that we don't know why these patients develop these mutations and develop resistance. That is there, but if you pay a lot of attention to nutrition and other things, you can combat that. Yeah.
Yes, one question. So, would you like to transplant a CML TP in molecular response, but having severe growth retardation as TKI toxicity?
So, see, that as I said, there are groups that are working only on pediatric CML, and there's no real consensus. A lot of this, you have to present the data to the family, see what their choices are. But you must tell them that doing a transplant, you can't say, okay, I'm doing a transplant and I'm going to cure you forever and everything's going to be perfectly fine. That guarantee is not there. As I said, we have CML transplants that we had done in CML-TP, but patients who did not have a good molecular response. And who now, after many years, have actually gone back to TKI. Maybe something, and I think you had also said that that could be an option, but again, we don't know. There are patients who will do well with TKI, with the tyrosine kinase inhibitors. There are patients who don't do well. If you don't do well, your decision is easy. If they are doing well, whether to transplant or not transplant simply for growth retardation, I don't think we have that data.
Attain menarche, nothing at age of 18, and
we haven't had any patients like that, so I can't say.
Your experience?
No, I don't think if you tell a family that you have like 10% chance of transplant-related mortality and 30% chance that despite transplant you will need TKI, nobody will go for transplant. And I personally, So I won't even offer, just for the growth retardation, I won't offer transplant with CML patient. I won't even offer.
All you need to do is good nutrition, follow endocrine.
And it is usually mild to moderate. Yeah. I must say that it is very unusual to see severe growth retardation, in which case we should look for other causes. Yeah.
Then look for growth hormone replacement and all those things rather than.
Yeah, even delayed menarche is
Last question, with availability of second generation TKIs, what is your take on it in the new patient with female TP?
So, in fact, the primary aim of management of CML is to achieve this molecular remission of BCR-ABL. And it has been seen in many trials that sooner you do it, the better it is. So definitely with second generation TKI, the chances of getting this molecular remission is faster, no doubt about it. But whether it really translates into long-term better outcome, at least in the pediatric population, it is not clear. So we do offer a newly diagnosed patient with CML second generation TKI in case they can afford it and the availability is not an issue. Otherwise, because we have GPAP program at our hospital where they get free imatinib and it has to be lifelong intake of medicine. So we offer only to patients those who are like financially well off. Otherwise, our 90% of the patients are on imatinib. Only 10% patients are on second or third generation TKI.
Dr. Mukesh, as a general pediatrician, I have a different question from all the oncologists. Basically, I am least interested how do you go into the remission, what you do all. I have no business asking you and knowing also.
And I have no business asking them to do the transfusion. That is all your job. The major problem that I face, whosoever goes to you and come back to us, he practically dictates us whenever they come for any interest. Write this, write this, write this. Because our doctor has said in this condition, this has to be written, this has to be written. And I always surprised why they come to us and they know the treatment. Because they have been following you for so long and for every time unless you have standard protocols which they have marked up. Now the query is writing for certain medicines like antihistaminics or antibiotics, is there a different threshold for it? Person who has come after remission to us, or it is the same threshold which we use for other patients? First. Second, let us do this first. Can you be in this any so the patient has completed treatment. Now it depends on whether the immunity has come back. Immune deficiency. In general, in most of the childhood management, immune deficiency occurs within 6 months of complete muscle. Post transplant, it may take 1 year. So after a year or so, immune system is same as that of any other thing. So you may treat like any other pediatric. But during the treatment, the patient is acute leukemia and for many things, like some fever or some illness. In that case, definitely one is putting that is why the patient gets, because we actually educate them so much about the importance of fever and neutropenia that you can't waste first average golden hour in to exploit doctor and get the antibiotic. So that is like our reinforcement of importance of the opinion. So during medicine, one has motive and especially the counter. In that case, first dose of antibiotic exposure. In general, the patient in the community acquired infections are generally not resistant. And so simple antibiotics that you give the other pediatric patient, if child is really toxic, you can be otherwise those antibiotics can be given. But as far as decongestant and antihistaminic and these are considered to be very illegal. There is no content. We would like to avoid any immune injection. We would like to avoid pain or cancer because these patients may have sometimes low protein and that means here it would paracetamol you don't from any antibiotic. I just want to add what Sandeep said. I totally agree with saying that after 6 months to 1 year of completion of this, patient okay and can go to a pediatrician and treat the way he wants. But if you have a patient who's on maintenance phase of this, who's on 6 MPs, 6 who's a neutrophilic, the neutrophil number may be normal, and the neutrophilic function may be disturbed. So if a patient who's on maintenance phase of therapy is coming to you, it is always better to take a blood culture and give a dose of antibiotic and talk to the friend. It's actually take care. primary oncology.
So my question to Dr. Tipur was this question in context of patients on therapy, or is this a lifelong phenomenon?
It's practically a lifelong phenomenon. I can actually name patients which have been treated by Dr. Gauri 20 years back, and they still come to me and take her name and say that write this.
They're overstepping. We are not responsible.
Might be they have been educated well by men.
I think that we have counseled them well.
Yeah.
And because the we want them back to the normal way in the community. But what happens is that thing is there. For everything they consult. काम है तो भी consult करेंगे, fracture हो गया तो भी consult. We try to encourage, but probably during the treatment, we have done so much counseling that it is good enough for right now. But I think that's with better communication with the pediatricians, shared care, very important.
So I think
we can't handle.
I think sometimes care and particularly focusing on immunization also following. Ma'am, I just request you to send all these follow-up patients for at least flu vaccination or something back to the pediatrician. Yes. Second question was regarding the reimmunization only. So just a quick 1 minute review when we should start after the remission. As you said, 6 months. So anything that can be given before that 6 months, and what all can be given after 6 months. Is there anything which should not be given between 6 months and 1 year?
Live vaccines after 1 year. Live vaccines after 1 year. Inactivated vaccines after 6 months. If they have missed any catch up.
Anything between rather before 6 months of remission?
Usually it is not remission. No, you can.
Stop in therapy. Flu vaccine can be given before that.
And in fact, the hepatitis B vaccine can be given, and as well, because A is big and rampant here, one can give a shot of A as well. During treatment can have either chickenpox or measles. Definitely cause of the because they can become vulnerable.
And if they have young siblings, the planning like a whole young siblings should not be given. Family, second child family.
We welcome Dr. Anurag Agarwal, President IP Delhi. And this is you have from such side there may be sometimes the role of the probiotics and other supplements, especially on the maintenance therapy. Many have doubts.
Probiotics and no participants during treatment, especially that they have, folic acid, and we don't know what it is because the mechanism of action is the 6 centimeter fixes. So please, I was going to say actually, it's okay to give antibiotics. It's okay to give paracetamol along with the antibiotics when we come with fever, but please avoid antibiotics. Most people will write multivitamin, calcium, this and that. Try to avoid.
Yes, thank you. We had a wonderful audience. We would like to honor some of the most interactive audience. So we will please call out. And Dr. Alka, she was the first to come in the morning and was quite interactive till the end. अब बड़े आदमी हो सर. Brother Jolie, please, you have come long way from Dibrugarh. Donachi is from Delhi only, but he was the second to come and was quite active throughout. First thing you asked. And he was actually. That's why he's there. Dr. Hans, please. Now for the secretary. Dr. Kelly. Sorry to put, ma'am. देखिए आपका फोन दे दो We are really thankful to Dr. Lika. She took her session last Sunday from USA. She came back especially for the workshop. Thank you so much. Dr. Mukesh. And we have a special honor for Mukesh. For our president, I believe Dr. Vikul, please. We have the certificates for the delegates. Sir, ऊपर आ रहे हैं certificate. So you just take the name and please do it for the certificates. Dr. Aditya, नाम लेके जाओ. Dr. Aditya. Dr. Aditya is Dr. Pramod Kumar. Dr. Pramod Kumar. Ma'am, lunch ready. Ma'am, lunch ready. Please start. Sir, Dr. Namrata Agarwal. Dr. Hans Vash. Dr. Jolly. Dr. Apurva. Dr. Nishan. Dr. Namrata. Where come from? Okay. Thank you. Dr. Nishant, Dr. Madhu Arora, Dr. Kamal Raina, Dr. Bhupnar, Dr. Amit Nagpal, Dr. Shreyasi Das. Thank you for coming. Apurva. Dr. Nishant. Dr. Madhu Arora. Dr. Kamal? Kamal? Dr. Pradeep Shukla? Dr. Rose Presser? Dr. Jasmine Singh? Dr. Pramod Kumar? Please give him. Yes. Dr. Amit? Yes. Dr. Sneha Bhosle, Dr. Nehal Singhal, Dr. Rajesh Kumar Malviya, Dr. Supriti Chauhan. Yes, come from Kerala. Yes, Dr. Sneha. Dr. Shyam Babu, Dr. Evelyn Bhutia, Supriti Chauhan. Dr. Shyam Babu, now. Is anyone less? Yeah. Please. There is a room in the left on the left side. Dr. Ajay would be there. You can take your certificates from there. And you can come and get your photo, please. What's that? ये खाली नहीं, ये इसकी भले नहीं फोटो निकाल Anyone else? This is for a photograph only. Certificate text links. Certificates are there. I thought we all thanks. Thank you. Available on the first floor, please join.